Start, sir. Please unmute.
Yes. Good morning, one and all. We welcome you all to the second session of this Magna Endo annual update. Hope you all had a good Endo
Madam, are
academic
you not
in
joining
the
the
last
meeting,
session.
ma'am?
I wish we will make it to the
11
same
o'clock,
standard
ma'am.
even today. Let us proceed further. Now I will hand over the session to the master of ceremony for this session, Dr. Anantharaman. Dr. Anantharaman, please carry forward the session.
Yeah, you can join, ma'am. You introduce the second speaker, no problem. Okay, you introduce the second speaker, no problem. I'll introduce you to this thing. I'll just join.
Anantharaman, please take over.
Yeah. Thanks for everyone for joining. Slight hitch because Dr. Lakshmi Lavanya has got the wrong information. She is supposed to start off with sharing, but she'll be joining us in another 10 minutes. I got information from her just now. Okay, so I'm introducing the chairpersons for this session. The first speaker will be introduced by Dr. Vijay Reddy, and then Dr. Lakshmi Lavanya will join in for the second talk. So Dr. Lakshmi Lavanya is American board certified endocrinologist, and she's a consultant in American Institute of Endocrinology, Diabetes at Hyderabad. She's a very prominent endocrinologist at Hyderabad. And it's a pleasure introducing Dr. Vijay Reddy, who's my mentor and colleague. So, I mean, we go back a long way. So, sir is a consultant endocrinologist at Vijay Diabetes Thyroid and Endocrine Clinic, Puducherry, and he's a president for Puducherry Diabetes Research Forum, and he's executive member of the Endocrine Society of Tamil Nadu and the organizing secretary of Endo 2020. He has published more than 15 endocrine journals. Over to Dr. Vijay Reddy for introducing the first speaker and the topic.
Good morning, Anantharaman. I thank organizers of Magna Endocrine Update 2021 for giving the opportunity to chair this session today. The topic for today, first topic is flattening the glycemic curve with alpha glucosidase inhibitors. So we know that it's not enough if we control only the blood glucose levels. We should do it with less variability. We should not have too much variability in the blood glucose levels. So for this, we have this topic about how to flatten the curve with the AGIs. So the speaker is my friend Dr. Babul Reddy. He is a consultant endocrinologist at KIMS Hospital, Hyderabad, and also at Elite Endocrine Clinic in Hyderabad. And he's done DM endocrinology from Osmania Medical College, and he's got state first in DM endocrine entrance, so he's academically very strong, and he has many publications, around 38 publications in endocrine journals. Over to Dr. Babul Reddy, you can take over.
Please unmute.
Yeah, thank you, Vijay Bhaskar, for the kind introduction. So in this session, I'm going to speak on this AGIs and the flattening of glycemic curve. Are you visible? Is it visible now?
Yes, sir.
Okay. Yes. So I would like to talk this session in the following outline. So first we'll discuss about the introduction about AGIs. Then we'll speak on glycemic variability. So after that we'll move on to the effect of this AGIs on glycemic variability. And finally I wrap up my session with conclusive remarks. Coming to the AGIs, so this alpha glucosidase inhibitors, They are there in the market since 1990s. So there is about 30 years experience with these molecules. And acarbose, meglitol, and voglibose are available in Asia and Europe. And coming to the US, only acarbose and meglitol is available. Among these three, acarbose is most extensively studied AGI.
Just 10.
And coming to the mechanism of action of AGIs, like AGI actually competitively inhibits the alpha glucosidase enzyme in the brush border of upper part of duodenum as well as jejunum. It is a dose dependent inhibition. So actually the action of alpha glucosidase is the degradation of polysaccharide to oligosaccharides, then monosaccharides. Thereby, the inhibition of this enzyme particularly causes less degradation of carbohydrates, so slow absorption of glucose happens. So there is delayed postprandial rise in blood sugars. And this alpha glucoside inhibitors are beneficial in both type 1 and type 2, and acarbose been approved in type 1 diabetes too. Then this is a picture I'm showing once again. The alpha glucosidase and the small intestine brush border, which inhibits, which actually carries the oligosaccharide degradation to monosaccharide. When you use this AGI, that actually inhibits this alpha glucosidase, and there is less absorption of glucose, then or delayed absorption of glucose, then only delayed postprandial glucose rise. So coming to the efficacy of these drugs, they are modest in efficacy. So the HbA1c reduction is about minus 0.8%. And as already we have discussed that the effect is predominantly seen on postprandial glycemia, but because of improved glucose sensitivity, they also have some effect on the fasting blood glucose. And coming to the adverse effects, as all we know that it is the commonest adverse event is gastrointestinal, that is flatulence, bloating, then diarrhea, and these are actually mild and occurs in dose dependent fashion. So over a period of time, if you start slow and go slow with these medications, these issues will be minimized because upregulation of this glucosidase enzyme happens in the lower intestine. So thereby reduction of these issues. And coming to the glycemic variability part. So glycemic variability means the oscillations of blood sugars which happens over a period of time interval. So which includes both. So it is postprandial peak, always nadir like hypoglycemic episodes too, and it's the glycemic variability component been recently well recognized, and it has been included as a variable in this glycemic pentad issue. So coming to this particular slide, I want to show that though the mean blood sugars of these three hypothetical patients are similar, but if you take the glycemic patterns, so if you take patient A, there is marked glycemic variation on the same day. So one area you are seeing at hyperglycemia, and other part you are able to see hypoglycemia part also. So, and coming to the patient B, where there is relatively small glycemic variations over a period of time. And coming to the patient C, though the glycemic variations are very little intraday, but if you take interday variations, there are cross variations been seen with this patient. So even though the HbA1c or mean blood sugar values are same in these three patients, the glycemic variations are different. So we are missing this glycemic variations if you just measure only HbA1c. Then coming to the other picture, I would like to show that when you use glycemic part with the finger prick glucose monitoring, you can see these two patients' glycemic variations are different, fluctuations are different. But if you check blood sugars at for these points, the blood sugars may be similar. So the importance of this slide again showing even if you are doing a serial monitoring of blood glucose with glycemic, finger prick blood sugar monitoring, we are missing this blood glucose fluctuations. So that is the crux of the picture. So we need to go with a better modality of investigation to pick up these fluctuations. So glycemic variability indices are like glycemic variability happens in a short-term basis or long-term. Short-term indices for glycemic variability are standard deviation, coefficient variation, MACE, and time in range. These are intraday glycemic variability indices. If you take interday glycemic variability indices, that is MOD and average blood glucose. If you take long-term glycemic variability, which been expressed with HbA1c, fasting, and PPS with point-to-point variation. If you take a fasting of blood sugar of that patient to other visit fasting blood sugar, if there is variation is there, then that kind of glycemic variability is a long-term glycemic indices. But is it easy to measure these intraday or interday glycemic variability indices? No, it is difficult. It is tricky because we need to have some kind of formulas to predict kind of glycemic variations. So how do we do this glycemic variability part in our day-to-day practice? So we can have this CGMS and AGP methods. So you can check glycemic variability on these indices very easily. I just want to show one picture. So here the left side of the picture was showing high glycemic variability and AGP with the undulating pattern of blood sugars, where you can see high sugars as well as low sugars. If you take on the right side picture where glycemic variability is very less, where you can see the flattening of the curve, flattening of the picture. So there is no marked hyper or hypoglycemic things in this part. And coming to the postprandial hyperglycemia, the importance of PPG. So if you see a type 2 diabetic patient, so he spends more time in the postprandial or post-absorptive state. Means the absolute fasting state of Indian diabetic patients, especially, is very limited, very small. So that's what I want to say. The PPG is an important contributor for glycemic variability. So then what is this glycemic variability issue? So is simply a theoretical part, or is there any evidence that this glycemic variability can cause complications of diabetes? Yes, glycemic variability being associated with both micro and macrovascular complications. And the evidence is through these studies. If you take this study, these various studies, they predicted the glycemic variability is associated with macrovascular complications. Coming to the next slide, so where this multivariate analysis has shown the MAGE is similar risk like smoking, hyperlipidemia, and hypertension. There's a traditional risk factor for the CAD, and the MAGE also included as similar as that in this multivariate analysis. Coming to the microvascular complication, yes, this glycemic variability also associated with microvascular complications. These are the various studies which actually had shown there is an association between the glycemic variability and microvascular complications. So till now, we have discussed what are AGIs and what is glycemic variability, what is the evidence of glycemic variability with various complications of diabetes that we need to target for. Then coming to our next slide, that what is the effect of this AGI on this glycemic variability? So we are talking about glycemic variability, that is the fluctuating blood sugars, whether AGIs can minimize these fluctuations or not. So I just want to symbolize this slide by showing like AGI usage which actually flatten the curve. So is there any evidence? Like it is only theory, again, is there any evidence? Yes, we are going to see in our few slides, next few slides, about the usage of these AGIs and across the across the diabetes spectrum to see the benefit of AGIs in type 2 diabetic patients. The first study I want to show where the acarbose been compared with metformin in a type 2 diabetic patients who are using pre-mixed insulin over a 12 weeks period. So in this particular study, they studied acarbose 100 mg TID with 500 mg of metformin over 12 weeks, and the outcomes being studied, the primary outcome is like seeing glycemic efficacy as well as the glycemic variability. And this is a 12-week period study. Actually, the study concluded that though the glycemic control is similar between two arms, but if you get this glycemic variability part and both short term, that is 12 weeks, that's what we can say it is short term glycemic variability indices, all these are significantly reduced in acarbose arm rather than metformin arm. The same picture once again I'm showing. So where you can see other parameters, in most of the parameters, both fared similar. Coming to the fasting blood glucose, as we expected, metformin is better than numerically better than acarbose. Coming to the postprandial, where significant reduction of postprandial glucose with acarbose, but final thing is glycemic control is similar, but glycemic variability is better with acarbose part. Then coming to our second study where acarbose been used as a single dose versus 3 times usage of acarbose on insulin treated patient to see the glycemic part. Again, glycemic variability is better with acarbose TID versus acarbose OD group in this particular study. The same thing once again I'm showing that MAGE part or 24-hour blood glucose fluctuation part being better with usage of acarbose here. And coming to the third parameter, the very important, where we can see the hypoglycemia time is also grossly reduced in acarbose. This is because when you use acarbose, the insulin dosage being reduced, so the chance of hypoglycemia is less with acarbose than placebo group. Coming to the usage of this AGI in patients who are on DPP-4 inhibitors. So this particular study was showing the addition of acarbose on allogliptin patients. So where you see there is flattening of curve at post breakfast and post dinner area, even though there is reduction in post lunch blood sugars too, but it is numerically significant but not statistically significant. This picture was showing the usage of acarbose again flattened the curve in patients who are using DPP-4 inhibitors too. And second picture where patients who are on vildagliptin with metformin, addition of acarbose again reduced this glycemic variability, that is MACE part and standard deviation part, and the component of time in range. Time in range again a component of intraday glycemic variability indices. So again which was showing better with usage of acarbose. Then coming to the other group of patients, like where metformin alone, like in uncontrolled diabetes with metformin, where addition of glibenclamide versus acarbose to see the efficacy of these agents on glycemic variability and glycemic control. Again, the picture is showing the glycemic variability is less with usage of acarbose. Here, the acarbose 50 mg TID compared with 5 mg of glibenclamide. So significant reduction of glycemic variability indices with the usage of acarbose. So this is a picture, same thing, both SD, MACE and MOD are grossly reduced with acarbose usage than the glibenclamide part. And coming to our first, that is a few slides back where we discussed about glycemic variability, the glycemic pentad. In glycemic pentad, each variable, that is fasting, PPBS, hypoglycemia, glycemic variability, and HbA1c, each component has its own role in CV risk part. So this AGIs act at every component of this glycemic pentad, especially on postprandial glucose, hypoglycemia, and glycemic variability part. So though it is significantly reduced all these components effectively, these three are more related with the usage of AGIs. And coming to our conclusive remarks part, AGIs are effective and safe medications. They are available over a period of time. So they are insulin sparing kind of, they have insulin sparing kind of action. They are non-hypoglycemic agents and they are weight neutral part. And coming to the glucose variability, the glycemic variability is physiological actually, can be seen in every individual, but the that high glycemic variability index patients can have more complications, especially in type 2 diabetic patients, both micro and macrovascular complications. Coming to the usage of AGIs on this glycemic variability, they are effective in reducing glycemic variability because we have high postprandial spikes. Usage of these agents flatten these spikes across the spectrum of diabetes, whether patient is using only insulin or patient is using other OHAs like sulfonylureas DPP-4, everywhere the usage of AGIs have an effect on this glycemic variability. So with this, I'm closing my session. Thanks for the chairpersons and thanks for the Magna group of people for giving this opportunity. Thank you.
Thank you, Dr. Babu. I think you finished exactly on time. It's an exhaustive presentation.
Dr. Lakshmi Lavanya, if Dr. Lakshmi Lavanya is there, Madam, can you initiate the discussion?
Yes, thank you all. My apologies for joining in a little bit late. I got the agenda a little wrong. I was thinking it's 11:30 and Sunday is my outdoor activity day. So I hope you all are welcome to the program. I would like to start by saying that Dr. Babul Reddy did a great job in bringing this non-dramatic, but a very useful, anti-hyperglycemic agent in the armamentarium of controlling sugars, where we have so much choice, but we still want safe choices, a very safe choice and an effective choice, especially for a postprandial hyperglycemia coverage, a balancing of intraglycemic variability in the same patient, day to day, time to time, postprandial to preprandial. Again, having something very, very safe in order to prevent hypoglycemia, weight gain, cost, ease of administration, ease of taking it, adherence, and also cardiovascular benefit. So great. I mean, this is an agent that we kind of, let it go on the side rack. We don't talk about it as much. So AGI is bringing it up to the table and bringing a nice presentation, especially comparing it with glibenclamide. I think Dr. Babul did a great job in all those slides and his own views he presented. Thank you, Dr. Babul, about that. But any questions from the audience? Can we take the questions now or later?
There is one question from the audience. Dr. Somasundaram is asking us, which of the two AGIs is better? Is it acarbose or voglibose? Which one is better? I think it is open.
Dr. Babul, yeah. I would like Dr. Babul to take over that first. Yeah.
Yes.
Since he probably did all his research. Yeah.
Yeah. So actually, there is the extensive literature is available with acarbose rather than voglibose. So coming to our day-to-day practice, where you will see, voglibose has a bit lesser kind of gastrointestinal issues compared to acarbose. But when you use acarbose in a slow, like start with 25, then gradually increase 25 TAD, then 50 TAD. The effectiveness actually I have seen better with acarbose than the voglibose.
Yes.
So that's my point. But
exactly, Dr. Babul. I agree. I also agree. I mean, I would want to add my point that we usually give them. I think voglibose has a little bit more of an upper GI belching and GI reflux, and the upper GI symptoms are failure of voglibose a little more than acarbose. And I feel the efficacy of acarbose is a little more than voglibose. Studies also are comparing the similar. I can't recall the names of the studies. I can't quote the study publications, but many of the studies also support a little less side effect profile by acarbose. And we can actually give, as he said, 25 mg TID to have a better postprandial hyperglycemia control, and then increase it to 50 mg, whichever meal is rich in carbs. You can go up to 50 mg 3 times a day also. But then when that comes to that point, the cost is quite high also, and the compliance is a question. My take also, I like acarbose better. We also use acarbose especially for those hyperinsulinemic patient, post-gastric bypass. So that is one agent, only one agent that we have in choice, isn't it, Dr. Babul? And we all use that, and it's much less seen here in India. In US, I used to be able to use acarbose a lot because we had a lot of those gastric bypass patients having that nisidioblastosis. Nisidioblastosis is that post bypass hyperglycemia due to hypoglycemia due to hyperinsulinemia.
Yeah, reactive hypoglycemia.
Reactive hypoglycemia. We see less of that here, and we can correct it. It's called elementary hypoglycemia or reactive hypoglycemia, and we usually correct it with a mixed meal, a diet class.
Right.
But in the US, that was a big problem, Dr. Babul and all the other audience out there. So we would use acarbose in place of any other agent for that particular condition. But I think, any more questions? Thank you, Dr. Babul, for answering that.
One more question from Dr. Sriram Mahadevan. So who's our next speaker basically? So he's asking us on whether acarbose, voglibose have a pleiotropic effect of DPP4 inhibition, and is there any clinical evidence to show any synergy with gliptins? So I mean, is there any synergy in the sense that sum is more than the parts kind of thing? Do we have any evidence for that? And does it have a effect of DPP4 inhibition? This is what Dr. Sriram is asking.
I am not aware. I'll let Dr. Babul talk about it.
Yeah, only thing is like the action of acarbose because of slow, the delayed absorption of these nutrients. and more like the delivery of these nutrients to distal ileum. Because of that, there is increased GLP levels. So theoretically, definitely there is the effect will be enhanced if you use in combination with 3PP4. In my personal experience, again, I'm saying, so usage of this, I use most of the times the usage of this acarbose with metformin in the morning, and I give one shot of DPP4 with metformin in the evening. That actually gives better result than either drug usage of BD dosages. If you use Vilda with metformin twice versus acarbose with metformin morning and Vilda with metformin, that actually I have seen better results than the either drug alone. That's my take, but I don't know the studies and whether it has been shown in that or not.
Then one more question, very elementary question, but then, you know, it will be of benefit to our audience. Why should be taken with food? Being asked by Dr. Somasundaram. And also another question, Dr. Sambit Das is making a comment that some evidence that there is increased level of GLP-1 with miglitol, but you know, query effect with DPP4 inhibitor. So I don't. He says that, you know, there's not much effect with DPP4 inhibitor. So you can take forward the answer to that question, where how it should be taken with food.
That's theoretically, definitely we can we advise patient to take this AGIs with first meal, that is along with the first bite of meal. But again, I have studied some kind of literature where it has been shown to be effective even if you take 30 minutes after the meal also. So when you use it with metformin, again you can take I think after meal also, but here it is along with meal. About Meglitol thing, I don't know experience about Meglitol, because Meglitol part being not available most of the centers too.
Okay, Dr. Babul, you've shown that a lot of effect on glycemic variability and cardiovascular studies are there with acarbose. But somehow in these ADA guidelines, the alpha glucosidase inhibitors never figure. So it's not in fashion in US, or why this alpha glucosidase inhibitors never comes in the ADA guidelines. Madam, Lakshmi Madam, I think you also told that you used for nesidioblastosis. But in ADA guidelines, they never mention about alpha glucosidase inhibitors at all. What is your view on that?
Yes, sir, you're right. Actually, Dr. Vijay Bhaskar, it's never on the guidelines, never on the prescription also as much in US, because it's not a cost-effective risk-benefit management. You know, like how much you're spending on the drug and the efforts to take it 3 times a day. It's a pre-prandial. And there's carbs in every meal. Most of the meals have carbs. If it's not rice, it's maybe fruit. If it's not fruit, it may be dessert. So whatever it is, there are some carbs in both continental and Indian diets. So you need to take it 3 times a day. So, it's not like they think it's the efficacy of HbA1c lowering effect as compared to the, the cost of it or the compliance of taking it is not matching, because it's not a predominantly carb-rich meal that they have. Like breakfast is bacon, eggs, and omelette or something like that. So sausage, bacon, eggs. It's completely protein. Lunch could be grilled cheese salad, grilled chicken salad, and there is maybe a small amount of potato or a fruit in it. And dinner maybe like steak. So it's the continental diet does not require that you take it, but some of the diets are very, very carb rich, like they may be having pizza or pasta or something like that. So making it a sporadic intake of this agent doesn't suit. I mean, it's not a regular thing that you can advise your patient. So you have to give them the special instructions. So it becomes a nuisance. It is basically AGI. I'm sorry, I don't want to say it like that, but practically American doctors think of it like a nuisance medication, not really much helping, but an addition of a tablet, especially 3 times a day. It just drives the patient nuts to think, okay, I have to take it 3 times a day or 2 times a day with all that cost and insurance coverage. And it doesn't do much. So that's why it gets dropped. Mostly, they go to metformin, sulfonylurea, and then the DPP4s, and then now SGLT2, and again insulin. So when you have insulin, prandial and basal. So when you have prandial, basal, or sulfonylureas coming into the picture, AGIs lose their essence after the sulfonylureas come into the picture. AGI play a role before the sulfonylurea come into the picture. After DPP4 and metformin, AGIs do their role. I mean, in India also. But in US, there is not even in the guidelines because they think it's just of no value. I'm sorry, but that's what they think. And after coming to India, last 10 years, I've been prescribing AGIs more. And I must confess that it is a wrong thinking of the American doctors or the Western medical practices. And it should be brought up into the guidelines at least, because guidelines are followed all over the world. And guideline not having AGI in their armamentarium is a very, very wrong message that you're passing to the entire world. And IDF has brought it up actually. They have written letters to ACE and ADA. And it should be in the guideline, in the vertical algorithm, Dr. Vijay Bhaskar. I mean, if that answers your question.
Thank you, madam. Quick comment from Dr. Babul Reddy, and then we move on to the...
Yeah, he has something in mind.
Yeah, there was a recent meta-analysis when I am going through this talk. So actually in this meta-analysis, they have shown there is reduction of the onset of new type 2 diabetes significant with the usage of whatever, whether it is acarbose from stop NADM to voglibose phase 3 studies and all. But when coming to cardiovascular issues especially, so their take is neutral. But why they said the same point is because the events happened in this group of patients are very less. So they have not taken kind of conclusive remarks that whether beneficial or not. At this point of time, the studies are inconclusive. But when the docking study, actually, if you take, there is 11% reduction of CADs when they followed up for 6 to 8 years. And all these studies where the cardiovascular studies been with this AGIs, like 3 years, where the maximum number of events happened about 48 in one study. So with that, we cannot get some kind of conclusive remarks. That's what my point is. At this point of time, there is substantive evidence is there in reduction of new onset of diabetes on cardiovascular issues along with ACE. Recently concluded ACE study also shown the same thing. There is some numerical benefit, but there is no significant benefit on cardiovascular issues.
Thank you, Dr. Babul. We'll move on to the next talk. Lakshmi, madam, you can introduce the next speaker.
We have Dr. Sriram Mahadevan. He is here from Chennai. He is now, currently professor and head of Department of Endocrinology, Diabetes and Metabolism at Sri Ramachandra Institute of Higher Education Research in Chennai. He also has his practice as a consultant endocrinologist at Sundaram Medical Foundation at his private clinic. He has published more than 90 papers in reviewing in all the honorary national as a professor in IMA, and also he has worked as a vice president, in finance secretary of Endocrine Society of Tamil Nadu and Puducherry. He's also executive committee member in ISMBR from 2019 till now. Special interests are thyroid, metabolic disorders, metabolic bone disease, and gonadal disorders and diabetes, where most of his research and publications and clinical practice expertise goes into. Dr. Sriram, it's a pleasure that we have you here as a next speaker. You will be taking on to the next topic. Sorry, if you can just bring me to the first slide deck.
Yeah. Thank you.
Yeah, Doctor. Yeah, thank you, sir. Please, you can take over the dais now, sir. Thank you.
Thank you, Dr. Lakshmi, and as my other chairperson, my friend Dr. Vijay Bhaskar. Profuse thanks to the Magna team for inviting me again for yet another update on endocrinology and diabetes. And my job for the next 20 minutes is to give an idea on. This is intriguing. Santosh called me and said that initially it was rethinking solutions to reduce burden of hypoglycemia. That would have been a very broad topic in diabetes with a lot of scope for discussion on the recent oral anti-diabetic drugs, especially SGLT2 inhibitors and others. But they later added that it should be with insulin. So I will definitely give you our thoughts on this. And before going, my slides are moving. Are you able to? Hello?
Yes, sir. We can hear you.
No,
your slides are also.
Slides are moving. Yeah.
Yes, sir. They are moving.
Yeah. So this talk specifically, conflict of interest will include the insulin-based companies but I will be as unbiased as possible, and you can take the slides in that context. So initial couple of minutes I'll spend on discussing hypoglycemia in diabetes in general, how common is it, and the consequences, and more data coming up on the seriousness of identifying hypoglycemia, especially in type 2 diabetes management. Much of our discussion over the next half an hour will be only around type 2 diabetes. And among the insulin treated patients, how should we reduce the risk? Obviously, every insulin, once it enters the circulation, is going to act, and there is a potential for hypoglycemia with any insulin, especially once it enters the circulation. Only the kinetics of absorption vary between the insulins. And all insulins are, before I proceed further, we have to take the background, the concept very clear that they are all unphysiological in one sense, and that is the endogenous natural secretion, physiological secretion of insulin is in the pancreas, and it's into the portal circulation, it goes to the liver. How much ever you modify the insulin and give it subcutaneously, it goes into the peripheral circulation first, and which has its own differences with the endogenous way in which it acts. So the reduction of hypoglycemia is to be seen with in all these contexts. Then a common question asked, there are so many newer insulins, so many analogs, are they anyway better? And I will discuss a couple of slides on comparison of these analogs with the conventional insulin. And in the last few years, we have insulin co-formulations with GLP-1 analogs, especially the short-acting ones like lixisenatide, as well as the other one, liraglutide also we have a combination. Does it have any advantage in hypoglycemia? I will show you a couple of slides on that. And is it the type of insulin or the injection or the delivery techniques which matters? And some upcoming newer innovations in this which add thoughts and more research into this, we will discuss last slide. So I will try to be as brief. And this is the first slide to give us the idea of the prevalence of hypoglycemia among type 2 diabetic patients. One large questionnaire-based study, self-reported hypoglycemia, more than 19,000 odd patients. And you can see here severe hypoglycemia to the tune of 2.5 events per year. And this could be much more. I'll show you a couple of our own small information. We did a small study a couple of years back to show that the incidence of hypoglycemia among our patients, around 400 patients we had interviewed, and the people on insulin or with sulfonylurea, it's very obvious that they will have more hypos, and around 2.5 times more than the other people in the same group. This is from Rural Health Center of our college, a recent publication of us, again showing that the prevalence of hypoglycemia in rural, the main agent used in this center is, most of them are treated free by the institute's provision of sulfonylurea, which is mainly glipizide and metformin, and it was to the tune of 57%. But these are all questionnaire-based informations and most often not documented. But hypoglycemia requiring assistance and admission was to the tune of 10%. So one can imagine then how much of the problem in India we are going to face, especially with sulfonylurea and others, and on the top of it, if they are on insulin. So this goes without saying that we are facing a big burden, and we will discuss what are all the ways in which we can reduce this. So the impact of hypoglycemia, thanks to Dr. Babul Reddy, he has also mentioned about the seriousness of hypoglycemia in his talk, and how the alpha glucosidase inhibitors in the previous talk was shown to reduce the incidence of hypoglycemia, reduce the dose of insulin. That's also one of the ways in which you can possibly reduce. That's also one of the measures. But hypoglycemia, especially recurrent episodes, even subclinical episodes, are known to be associated with serious vascular events, as well as we all know a patient who is going into neuroglycopenic zone of hypoglycemia will have serious effects, including seizures, coma, etc. That's fortunately very rare in the typical type 2 diabetes patient. I'm not going to discuss hypoglycemia unawareness, which is a very serious effect where the patients without any warning signs will directly go into the neuroglycopenic zone of hypoglycemia and directly present with unconsciousness. So recently, after the ACCORD study showing that stricter control of diabetes in our elderly patients is definitely having some association with cardiovascular morbidity should be kept in mind. And our primary aim in most of our type 2 diabetic patients who are 60 and 70 plus with more than 10 to 15 years of duration of diabetes is to reduce the hypoglycemic episodes rather than being too strict with diabetes control. This is a gross message we have tried to convey in the last couple of decades, especially data from ACCORD study. So it is a big challenge in every diabetes, including type 2, and this will be even more complicated in type 1, to achieve strict control of diabetes at the same time reducing the risk of hypoglycemia. Because one episode of hypoglycemia or a couple of more episodes, it not only instills a fear in the patient, also in the bystanders, the relatives, the caretakers. I'm sure stricter control will never be that easy in that same patient. Recurrent admissions, increase in cost, the fear leading to reduced quality of life is beyond any measurable metrics we can use in this. So I think it's not only budget and economics here, but quality of life also. So at the end of the day, any kind of diabetes therapy, reasonably good control at very reduced or minimized risk of hypoglycemia should be our aim, and that's why newer agents are being discussed. And in the next 10 minutes, I'll discuss on how to reduce in patients who are on insulin therapy, that is the top. Here, again, there is a problem in interpreting the data. Many studies are available with respect to insulins, newer insulins, their hypoglycemia risk, etc. The definitions used in some of these studies are varying. And this is the ADA and the International Hypoglycemia Study Group recommendation, I can say, to clinically follow some of these cutoffs. For example, the level 1 is less than 70, 2 is 54. Even though these numbers are also carrying meaning, the glucometer, the way it is done, the estimation error and all should be factored when you are discussing this. And the last one is easiest and to identify, especially because a person who is requiring assistance or he becomes unconscious or having serious cognitive impairment is the most easy. And maybe these agents should be compared. When I say that this insulin is better than that insulin, etc., should be compared only with level 3 hypoglycemia. That is what the purists or researchers say. But we know as clinicians and practitioners that level 3 hypoglycemia can be documented and they are hospitalized, and data is not that difficult to get in a big hospital. But the level 1 and 2 are also important, and we understand how difficult it is to tell a patient to slightly increase the dose of insulin to keep the A1C under control, but they will say that I am having symptoms of shivering, some hunger, those kind of symptoms which are even at the glucometer reading of 100 or 150. So that's where I think we should use our clinical judgment, and these are all guidelines to tell us that this is the level at which you have to lower your threshold of stricter control. So coming to this vexing question, does the type of insulin matter? We know the marketing force. We know the newer insulins which are being propagated. We understand that they have very clear advantages. And for the last, this is 2021, which is exactly the first century completion of the discovery of insulin, and it's coming into the market. After that, you can see over the last century, so many new insulins and so many modifications. And the latest ones are not only co-formulations, the same glargine with a higher concentration, having a longer duration of action, etc., have been come. So the immediate thing is, based on efficacy, most of these are roughly the same. As the saying goes with respect to technology, I think that is applying to insulin. So technology is best, and it depends on the user. It is as good as the user, they say. Same way, I think insulins or the kind of insulins or the delivery techniques, etc., is as good as the person who is using it. So a lot of education on the kinetics of this insulin and how they act and how we have to modify our lifestyle or the dietary habits based on that will go a long way in using this insulin appropriately in reducing hypoglycemia. So just because you switched over to a newer insulin may not always mean that the patient will have lesser hypoglycemia, because ultimately, once any of this insulin enters the circulation, it's going to act only for the next 3 to 5 minutes. The T half of insulin in the circulation is less than 5 minutes. and is going to cause its effect, and hypo also if there is a mismatch in the carbohydrate load and the dose which has got absorbed. This one slide will be a summary of all the newer insulins when compared to the hitherto existing standard insulins. For example, on the left side, the Glargine U100, which we were using for more than 1.5 decades, is compared with Detimir and NPH. And in those controlled study setting, the episodes of hypoglycemia, especially nocturnal hypoglycemia, was definitely less with Glargine. And the commonest reason quoted in all these papers is when compared to the NPH, with which at that time they studied Glargine against NPH, the NPH has more peaks, and erratic absorption is what is the usual quoted explanation. And that could lead to more hypos, especially if you are using it pre-dinner, and there will be a late night peaking of NPH, which will cause hypoglycemia. And these analog insulins, especially Glargine and Detimir, both had very significant lesser episodes of hypoglycemia when compared to NPH, and we have been using it for a long time. But please remember, use your clinical judgment. Patients should take any of these insulins. I'll show you a couple of interesting recent things on NPH also in the next couple of slides. Then the Sanofi people brought up the concentrated insulin, the same Glargine, which is acidic in nature, when concentrated to the tune of 300 units per ml, actually acts longer, and it has a profile which is much more flatter. It was very intriguing to see some of these same presentations by the same company people, that when Glargine was compared with NPH also, they said this Glargine is very flat in profile, 24-hour long profile. But once Degludec and Glargine U300 came, that same U100 Glargine became more peaks, and the same 24-hour profile was somehow underplayed in these presentations. And Degludec, which is the novo insulin, recently last decade it was introduced, and very interestingly, very importantly, Degludec in combination with aspart is a very, very useful tool in our day-to-day practice. And Degludec has a very flat profile when compared to U100 Glargine. One bottom line of all this is, cutting across any of these studies, the incidence of hypoglycemia with respect to these newer insulin analogs, especially the long-acting analogs, are very, very low when compared. But again, education matters. Please use it appropriately. These two slides is just to re-emphasize the fact, and I was surprised that these publications are coming just 5-6 years ago. This is the same NPH in our standard vial or in a pen. You see here, they get sedimented. And appropriate resuspension by vigorous rolling for at least 20-30 times before injection is a very simple way in our low cost resource constraint setting to increase the duration of action of NPH. It's a very common error done by most of us, our patients, and I think education is the key. And these are all scientific evidence to tell us again and again that the same NPH will definitely act longer if the whitish part or the sedimented suspended part is better. And you see how it can easily separate into the regular insulin and the protamine zinc preparation settling on the top. And this has to be told to the patient. And this is a study as recent as in the last decade to tell us that if you do good mixing, the same NPH will act longer if you resuspend it by vigorous shaking or by rolling for 20 times to 30 times. So these are all a couple of our small observations. I think all of the clinicians or senior people sitting here and delegates will know the technique of injection is also a problem if you have to reduce. And this was the time when we were studying in Chandigarh. There, bovine insulin was used commonly. The older insulins had these kind of lipoatrophy and hypertrophy, which is not at all seen now with the newer all-human insulins. But even as recent as a couple of years back, we had injection technique related problems. Intradermal injections or taking in wrong places, using the same needle for more than 3-4 times. And all these have to be, examination of the injection site is a very, very important thing. Rotation of the site, giving it in the same fatty area, especially in the abdomen, etc., should go in a long way in preventing hypoglycemia in our patients. So putting all these together with the newer evidence coming with the ultra long acting insulins, the Cochrane review when compared with NPH, this is last year's publication, telling us that definitely these analog insulins like Glargine, Detimir, and the recent Degludec, that was not included in this Cochrane review, but they all reduce hypoglycemia when compared with NPH. No doubt about it. However, serious hypoglycemic episodes were rare. So this is, as you know, Cochrane group or independent group, not industry biased. So approximately 1 in 100 people treated with Detimir instead of NPH actually benefited. That means to say that in most of your type 2 diabetic patients who have some endogenous insulin secretion which is still there and who are elderly, who do not need that stricter control, I think NPH will do the same job as most of these analog insulins. However, in type 1 or in younger patients who need stricter control, definitely the analogs, ultra long acting analogs have a definite advantage. And that's the overall conclusion of this Cochrane data. So adding some new informations for the academic PGs or somebody who may be listening to this talk is last year we had another new insulin from the same Novo group. We have to thank the Novo kind of original research, their team innovators. So many new insulins were introduced from Detimir to Degludec to the IDEG ASP. Everything was Novo's innovation. And this is one more thing, adding one more feather to their cap is ICODEC insulin, which is a once weekly formulation, the recent NEJM publication, which was a double dummy randomized trial comparing ICODEC with Glargine U100 in patients who are on metformin or metformin with DPP-4 inhibitor. People who were on long-term insulin already or sulfonylurea were excluded in this study. And this showed that the A1C control of ICODEC was comparable with Glargine U100 with almost the same or no extra risk of hypoglycemia in that study. Only numerically there was some difference. So how it will come into the market and how we are going to use it once a week and what happens in between, etc. I think more and more studies have to be done. But fortunately, this will have a very, very low, flat, ultra flat, I can call it almost a flat profile, and that may help in our patients who are prone to hypos more frequently. So this is an addition to what is the information already available. So does this insulin plus GLP-1 analog, which as I said, we have this liraglutide with the long-acting insulin Degludec, or we have lixisenatide with Glargine combinations which are in the market. And we know how GLP-1 analogs per se are very low to a propensity to cause hypoglycemia. So in addition to insulin, do they have an advantage? But contrary to what I believed when we looked at this meta-analysis published a few months back, but though in these studies, the HbA1c and weight gain were all prevented by the addition of the GLP-1 analog, hypoglycemia was unfortunately not lower when you combine both. Exact reasons are not discussed. Obviously, it's a meta-analysis, pooling of all the studies. There could be bias in the way they were included the thing. But overall, this seems to be not a great combination, at least with respect to hypoglycemia. So having discussed the type of insulin, ultimately it is the user and his education matters. Newer insulins have an advantage if you have stricter control. Does the delivery of insulin, I already mentioned about the injection technique and its flaws. Now, does the delivery system reduce hypoglycemia? This is again a simple chart showing how much we have advanced in the last few decades, right? From the initial introduction by Lilly of the insulin in 1921, you see here, today we have the pumps, so many modifications. I'm not that techno savvy to go into all these details, but to tell you that the ultimate pump will be something which closes the loop between the data given by the CGMS and the pump, which is automatic. So many modifications have done. Thanks to this initiative of do-it-yourself artificial pancreas system. This was formed by the people, parents of type 1 diabetics or relatives who are technology savvy people who formed their own initiative. And they said, we are not waiting for more doctors and others to go into this. So there are so many softwares available today where insulin can be given to a child or somebody with type 1 or on insulin with the algorithm derived from their CGM data. But a lot of such things require FDA approval. But cost again is a precluding thing in many of our Indian patients. So I won't dwell into this much more, but this is going to be the near future. And as you know, how technology has come into diabetes in a big way. And more research is also being done because the topic is on insulin and hypoglycemia. There are quote unquote smart insulins. We have smartphones now. So there is some big research going on. There are big reviews being written on how to make the insulin glucose sensitive. This is a very catchy term. How they make is insulin is packed to carbohydrate polymers which react with the ambient glucose, and only if it is higher, the insulin is released from those complex polymers which are embedded subcutaneously, etc. So this is again in the research setting, but I thought I'll just mention in an academic meeting like this. So coming to last couple of slides on clinical aspects, which I think the clinicians should remember. Ultimately, it is not the insulin alone that I have mentioned repeatedly. How you use it, how much you educate. So correcting the other factors like secretagogues, like for example, sulfonylureas, you have to reduce the dose if you are giving insulin along with that. And recently, the SGLT2 inhibitors are acting very potently in many of our patients. So we should reduce the dose of insulin when you are starting such therapies along with insulin, and look at kidney problem, look at any adrenal issue, look at any steroid withdrawal, look at the alcohol intake or elderly who is not eating well. There are so many psychosocial issues. So all these will carry a very big meaning in a given patient who is on insulin. So insulin reducing hypoglycemia doesn't mean changing the insulin alone, but all these factors, thinking of the patient holistically, addressing the other medical issues is going to be the key in most of our patients. So just to summarize that point again, that if you are seeing an elderly patient, please personalize the goals. Individualize the glycemic target based on his cardiac and other risk factors. HbA1c of around 7 to 8 may be better without hypoglycemia than actually being more aggressive in going below 7 and causing a couple of hypo episodes. So educating the patient, anticipating, recognizing, avoiding and treating hypoglycemia is the key in reducing insulin-treated patients with hypoglycemia risk. So in summary, I would conclude again by reiterating the fact that hypoglycemia is a big burden in our type 2 diabetes management, and had it been not for this condition, diabetes management would have been much easier. And it is very, very obvious to clinicians like us that insulin use is obviously associated with more hypoglycemia risk. However, how can we minimize? Education is the only key. Knowing, awareness, about hypo, first of all, educating them about hypo, identifying it. Then educating about the insulin, the technique, the kinetics, and how the meal insulin mismatch to be avoided. All these carry much more meaning in a given patient. And newer insulins, it's not to say that they are not useful, very, very advantageous, provided you use it in the right way. Thank you very much for the opportunity again, and I'd be too happy to take up questions or any discussion points. Thank you very much.
Thank you, Sriram. I think it was an excellent talk. I think you covered all the aspects of insulin usage, insulin technique, and other factors. In addition, about the insulin analogs, especially the newer basal insulin analogs. You also highlighted the occurrence of hypoglycemia with insulin with other agents like GLP-1 analogs and oral antidiabetic drugs. So you told along with GLP-1 analogs, how about DPP-4 inhibitors? Do they reduce the hypoglycemia along with insulin?
I'm sorry that I didn't look. I'm sure there will be a couple of meta-analysis, but I didn't look into that. Because I thought, this is an injectable thing. Since the GLP-1 analogs come along with insulin, I thought I will mention about that. Otherwise, logically speaking, if the DPP-4 inhibitors biologically, sometimes they are very potent in some of the patients. And that's a standard, a practice point that sulfonylureas and insulin doses should be reduced when you add DPP-4 inhibitors for the first time in a given patient. And that's a general point. And I'm not quoting any hardcore reference, but I'm sure that will be a point of use for our patients.
Dr. Somasundaram has asked a question: what is fast-acting carbohydrate in management of hypo?
Fast-acting carbohydrate is glucose. I think it is very nice that we are starting. I am following the alpha glucosidase inhibitor discussion. So the easiest available carbohydrate is sugar, but as you know, sugar is a disaccharide, sucrose. And patients who are on alpha glucosidase inhibitors, their absorption will be poor. So it is better. Today, fortunately, we have certain companies coming up with glucose tablet. So when I say fast acting, 15 gram means 4 to 5 tablets of that 4 to 5 gram tablets. So 20 grams taken immediately or mixed in a juice. Or if you don't, and wait for 10 to 15 minutes. So fast acting means something which absorbs quickly. So glucose is the best whenever you have hypoglycemia. If you don't know what agents they are taking, if you know that they are not an alpha glucosidase inhibitor, your routine sugar at home or chocolates, everything will act. But otherwise, only glucose will act fast.
So do you recommend that we stop sulfonylurea use when we use twice a day premix or basal bolus regimen, or you would continue sulfonylurea also along with insulin?
Yeah. I have 10, 15 years back during big meetings, I used to ask the same question in many forums. And some answers I got through interactions with others, as well as a couple of studies done by our Dr. Mohan's group in Chennai way back in 90s. That was the time when cost was also discussed as a big issue. So in his papers, you can see those papers in 90s published by Dr. Mohan's group here. They have showed that by continuing sulfonylurea like glibenclamide or glipizide, which was available then, they showed that the dosage of insulin actually comes down. See, in contrast to the routine endocrine other diseases where when you give something exogenously, we say that the internal axis will get suppressed and your internal secretion may come down. It is surprising that beta cell pancreas doesn't behave that way. So even a few days back, I had a patient who is more than 20 years diabetic. Glibenclamide of 5 milligram introduced by some other doctor caused potent hypoglycemia against all our routine thinking. And he is already on a small dose of insulin. So I actually reduce the dose of sulfonylurea, keep it on the usual doses. I don't go like glimepiride 3 milligram BD, 4 milligram BD and all. I never give. In the combination, sometimes it is used. 2 milligram is the maximum I use. Generally, this is my small thing. So answering your question is, sulfonylureas in general, if you see literature on whenever you intensify insulin therapy, they say that you stop sulfonylurea. That's how the trials will be done. But in practice, we continue a moderate dose of sulfonylurea. That may help in reducing the insulin doses probably. This is because some beta cell function is always there. The previous term like beta cell failure is not accepted anymore. Beta cells are still there and they may respond sometimes. With the insulin, if the glucose has come down, maybe the sulfonylurea will act. That's what is the answer probably.
Lakshmi Madam, any closing comments from your side?
Yes, sir. I wanted to actually pitch in for this because usually in the US, in our training, whenever we give a basal bolus therapy or a premix insulin therapy with a basal and bolus mixed premix, like Novomix or Humalog mix, we generally completely stop the sulfonylurea. We do not give sulfonylurea along with any rapid insulin at all. So that is the number one, because just like as Dr. Mahadevan was saying, that there is some beta cell function still there. There's always a residual, unknown, mysterious beta cell function, which just adds up to the rapid insulin, which is coming on board. You're giving rapid insulin because your postprandial blood sugar is not at optimal phase, optimal range. As a doctor, you have recognized there's some problem in the postprandial hyperglycemia, and you want to bring it under control. And that is the reason why you're giving them a rapid insulin or a premix insulin or a basal bolus therapy. So in that case, what is the point of giving a sulfonylurea? You would rather up your prandial insulin. You are not debating at a low insulin units here. You don't want to target a lower insulin units by bringing another sulfonylurea, which may add up to the trouble of hypoglycemia, which can be very, very horrible hypoglycemias in certain individuals, because you never know how these patients behave when there's a sulfonylurea plus prandial insulin for the amount of carbs and the activity that is going on match for them. There is always a hidden risk of hypoglycemia when you give sulfonylurea with the premix, which is again not there in case of DPP4, GLP-1, AGI, SGLT2. That hypoglycemia with sulfonylurea and premix insulin, it can be horrendous in certain situations, in certain lifetimes. We usually don't come across, that's why we don't know the seriousness of the situation. It doesn't hit our hearts as much, but that can be always there. And the maybe a standard of care should be never give them sulfonylurea. In fact, switch their sulfonylurea metformin to gliptin metformin combination, add an SGLT2 if you want, add a GLP-1 if the patient can afford another injectable costly preparation. But do not ever leave the sulfonylurea on board as it is. Always switch it off before you give your prandial insulin or a premix insulin, is what we learned and is what we practice. All American board certified You will never find a premixed insulin with a sulfonylurea on a prescription. That is our guideline kind of thing. But we see that Dr. Mohan's entire ground of Dr. Mohan's diabetologists from Dr. Mohan's across the South India that he's prevalent at the centers are, we always see a sulfonylurea with a premixed insulin, and it has never gone off the list. And I don't know why you're trying to debate a lower insulin doses. How does it matter to you if the insulin dose is higher or lower? You have to inject the damn insulin anyway, Dr. Vijay Bhaskar. I mean, you have to take it anyway, right? 16 units or 22 units. It doesn't matter. What matters is the safety of a prescription, the reliability of a combination of the entirety on board what the patient is taking. You don't want like two swords. You don't want one cup of tea and one cup of coffee also. You want either tea or coffee. So that's our take on it, basically. Thank you.
The last comment from Dr. Sriram.
No, Dr. Lakshmi, madam's point is well taken. That's what I commented, and that was a paper almost 2.5 decades back. And it was published in JAPI. You can go through that. And that time, it was important that the doses of insulin mattered in India. That's why in US, you will never have 40 units per ml vials available. In India, we used to have. And, these are all for some cost issues, but I agree by and large, that's how we practiced in our institute also. And as you put it very rightly, the practice among most of the South Indian doctors is to continue. And as I mentioned, how much ever you give insulin from outside, even if a small amount comes from the endogenous insulin, it may have some effect on the liver, which you are missing if you give a subcutaneous insulin. I think that's the logic. I think you can explore this more, and they may have some meaning more than what we think. And hypo, I agree, we have to. And in that context, these long-acting insulins, be very careful. If you have an hypo in an elderly person, you will have hypos for 2 days, 3 days. We had quite a few patients in the last year the long-acting insulin is safe, and they believe that it's too safe and give a dose. And if he has an hypo, you have to wait for 24, 48 hours in the hospital for it to go out of the system. I leave it there. Thank you.
Thank you, Sriram. I think it was an excellent talk and we had a lively discussion. We move on to the next topic, which is tackling time in range with generation 2.0 basal insulin. The speaker is Dr. Sambit Das. Again, he is my close friend and is professor of endocrinology from High Tech Medical College in Bhubaneswar. And he's going to talk about high-tech insulin also. So he's also endocrinologist at Endeavor Clinics and Apollo Sugar Clinics, Bhubaneswar. He has multiple publications and he was Secretary of Endocrine Society of Odisha. Over to Dr. Sambit Das.
Thank you, Dr. Vijay, for that wonderful introduction. At the outset, I must thank the team Magna for giving me this opportunity to be part of this wonderful program. So, hope my slides are visible.
Visible and audible, Dr. Sambit.
Right.
I think you have to move to slideshow, yes.
Yeah, correct. So, the topic which I'll be dealing for the next 20 minutes is tackling time in range with generation 2.0 basal insulin. And I'll be discussing the newer generation basal insulin, mostly the Glargine U300, to some extent the Degludec also. It's a conflict of interest. It's a Sanofi sponsored talk. Most the slide deck is prepared by them, but I have tried to modify a few of them actually to bring some neutrality. So the flow of my presentation would be that I'll be presenting the concept of TIR, or the time in range, and the clinical implications. The second is review of global recommendation, what is meant by TIR and where we should be using TIR. The third is addressing TIR with basal insulin therapy, how the time in range has been addressed nicely by basal insulin therapy. And the fourth is comparing the generation 2 basal insulin analogs in the light of TIR. And mostly it's a comparison of Glargine U300 versus Degludec. So coming to the concept of TIR, we know that the concept of glycemic triad has now been changed to glycemic pentad and hexad. So the triad were actually fasting plasma glucose, PP, and the HbA1c. Previously we were targeting the 3 of them, but currently there are 6 factors which we must try, and those are, apart from fasting, PP, and HbA1c, we must try for hypoglycemia, especially the nocturnal hypoglycemia, and the glycemic variability. Glycemic variability is also an important concept which we must target. Then what is glycemic variability? Glycemic variability refers to the fluctuation in the blood glucose, both peaks and troughs. And it may be intraday variability, that is within a day, how much fluctuation is happening, or day-to-day variability or the interday variability. And it has been shown in various studies that this interday and intraday variability leads to high oxidative stress, lead to increased risk of severe hypoglycemia, and also various microvascular complication. Though direct correlation with the macrovascular complication is a little bit less, but nevertheless they are there. So establishing glycemic variability, even if A1C is controlled, I think this sort of diagram we have come across many times, that is person 1, person 2 and person 3 have the same A1C, that is 7%, but it all depends on how many number of troughs and peaks the patient is passing through. For example, the person 1 has time in range which is almost at 18%, but most of the time it is high or it is low, but he or she is having the same A1C level of 7%. The person 2 has a little bit more time in range, but less time in high or in low range, but again the HbA1c is 7. And the person 3 has almost 100% in time in range and the A1C is 7. We want the highest time the patient should be in the time in range. So that's the concept of keeping the patient in time in range and avoiding high fluctuations in the blood glucose. So time in range and what above and below the range means, now at least 17 hours in a day or more than 70% of the time the person should be in a given blood glucose range. And as per the definition, the TIR should be between 70 to 180 milligram per deciliter. This is the bar which you can see, the column, and the time in range or the target range is around 70 to 180 milligram per deciliter. We call it as time in range. There are two values which are above. We call it as high or very high, or level 1 hyperglycemia or level 2 hyperglycemia. That is, if the blood glucose is between 180 to 250 milligram per deciliter, or very high when the blood glucose is more than 250 milligram per deciliter. Similarly, there are time which are below the range, and they can be denoted as low or very low, or level 1 hypoglycemia, that is between 54 to 70 milligram per deciliter, or less than 54 milligram per deciliter. We call it as level 2 hypoglycemia. So basically we want the person to spend more time in the time in range. So basically it should be around 70% of the time the person should be in the TIR, and at least less than 5% should be above range and less than 1% below range. So that should be our target basically. So what are the outcomes of TIR if it is not maintained? Suppose the person is remaining more in TAR or the time above range, or TBR or time below range, then what will happen? If the TIR is decreased by 10%, it has been shown in various studies that the microvascular complication is significantly increased. Say for example, the retinopathy risk is increased by 64%, nephropathy risk is increased by 40%, and the neuropathy risk can be increased by 25%. There are initial evidences also showing that some of the surrogate markers of macrovascular complication like carotid intima media thickness are adversely affected if the TIR is deranged by more than 10%. But the hard outcomes are still lacking for validating this TIR derangement and direct correlation with macrovascular complications. So that was about the concept of time in range and the clinical implications. Coming to the review of global recommendation on TIR. Now the concept of TIR has actually emerged in 2000 when the continuous glucose monitor were actually launched worldwide, and from there the concept has changed, and there was no consensus till 2012 when the Hemsley Charitable Trust, the first expert panel came in 2012, followed by in 2017 there was a systematic approach to CGM data evaluation. No unified recommendation though at that time, but the path-breaking thing happened in 2019 ATTD when there was an international consensus on time in range, and they have actually evaluated various factors and the various parameters of the CGM measurement, and then they have correlated with the different complication and what should be the time in range they have evaluated. And followed by 2019 ADA first time has recognized that CGM increases the treatment satisfaction, and they have also come out with the concept of TIR. In 2020, the ACE and ACE, the CGM assist in reaching glycemic goal safety has been validated, and 2020 ADA advocates the use of CGM in various patient profiles. And if we see the 2021 ADA, the CGM as an important tool for hypoglycemia prevention has been noted. So the concept is evolving. It's a newer concept and mostly based on the continuous glucose monitor devices. And there are newer consensus which is coming, and they are being incorporated by the guidelines. The ATTD 2019 recommendation, they have actually given different TIR and the different levels of the time in range for different age groups and different types of diabetes, and also for pregnancy. Say, for example, for type 1 and type 2 diabetic patients, the time in range is between 70 to 180 milligram per deciliter, and the patient should spend more than 70% in the time in range, less than 25% in the time above range, level 1, and less than 5% in time above range, level 2, that is more than 250 milligram per deciliter. And always try to keep less than 5% as time below range. And definitely severe hypoglycemia, level 2 hypoglycemia should be less than 1%. For elderly high-risk type 1 diabetes, or in type 2 diabetic patients who are elderly or having high risk, that is multiple comorbidities, then we must try to reduce the number of time the patient should be in the time in range just to avoid hypoglycemia. So the hypoglycemia, the person TIR should be less than 1%. The time in range should be more than 50%. Time above range, the patient may spend around 50%, but we must slightly relax the TIR concept in this group of population. For pregnancy, the type 1 diabetes, the time in range is exactly that of the adult type 1 or type 2 diabetic patient. At least 70% of the time the patient should be in the time in range, but the time in range, the range has been changed, that is 63 to 140 milligram per deciliter. For pregnancy, gestational diabetes and type 2 diabetes, the time in range is again 63 to 140, and most of the time, that is more than 70% or 80% of the time, the patient should be in the time in range if the person is doing a CGM at that time. So following the ATTD, a group of experts from almost 12 countries have sat down and formulated a concept of time in range for our specific countries. And they have actually discussed the time in range for different population for micro and macrovascular complications also. Like, for example, adolescents and adults, the time in range is almost similar to that of the ATTD, only the values of the range has changed. For pregnant patients, the lower value has come down to 63 and the higher at 140. That means a more stringent control. For elderly, it has gone a bit up, that is 90 as the lower limit and 200 as the over the higher limit. And these are all evidences based according to the small CGM study done in this group of population. Similarly, patients who are at risk of hypo, that is renal and hepatic disease, the range has been higher, that is 90 to 180, and less time should be spent on time in range, rather should be spent on more on time above range, and strict hypoglycemia has to be avoided. Similarly, for macrovascular complication, microvascular complication, it has to be more stringent control. People with concomitant infection, we should be targeting between 140 to 180. So like that. So that was regarding the review of global recommendation of the time in range. So the third point is addressing TIR with basal insulin therapy. So the suboptimal clinical utilization of the TIR has been there. We all have discussed about the TIR and the importance in the clinical practice and how it has reduced the micro and the macrovascular complication. But despite its demonstrated value, TIR is seldom used in practice or very less often used in practice. So what we can do in our practice, especially if the patient is on insulin, we should try to avoid going TBR or time below range, or going more frequently to time above range. So we should target the TIR, but if we are not able to measure, as TIR is important yet seldom measured, why not go for a treatment solution which take care of TIR even though not continuously monitoring. So Can basal insulin address the glycemic variability and TIR? Yes, the answer is yes, because glycemic variability with the peaks can be addressed by the basal insulin, because the basal insulin will bring down the whole glucose down. So even if there are postprandial peaks, but if the fasting, if we are fixing fast, then the whole blood glucose can actually come down. And basal insulin, like glargine, effectively controls the PPG excursion if we are adding with a bolus insulin. But if we are targeting the fasting and if we are fixing the fasting, then the whole things will settle down. For the TROS caused by hypoglycemia during the interprandial period, lesser risk with glargine and versus NPH, and lesser risk with glargine versus premix and co-formulation. This we have already learned from our previous speaker. But what is more important is that we have the basal insulin like glargine, which can reduce the glycemic fluctuation. But the second generation basal insulin, if we are giving, this is actually showing if you are lowering the fasting or targeting the fasting, the entire thing settles down. But if you're addressing that, targeting the fasting with the basal insulin of the second generation or basal insulin 2.0, that is glargine U300 or with the degludec, then the smoothness of the glycemic fluctuation will be established, and there will be still lesser glycemic variability, and more time the patient will land up in time in range. So there are grossly, or there are basically two types of basal insulin second generation, glargine 300 and insulin degludec. Glargine 300 has got similar molecular structure to glargine U100, but it acidic and forms microprecipitate in the subcutaneous tissue, 3 times more concentrated than U100, forms a smaller depot in the subcutaneous tissue and U100. So if we can see this diagram, then probably we can understand why the PKPD has been flattened with glargine U300. So since the reduction of the depot surface area by half in comparison to glargine 100 versus the glargine U300, it reduces the surface area and smaller amounts are released continuously, and probably that is responsible for a more flatter PKPD profile with glargine U300 versus glargine U100. The glucodynamics in the CLAMP studies, they have shown that even distribution over 24 hours with glargine U300 in comparison to glargine 100. And the clinical CGM study has also shown a more flatter profile with glargine U300. The all metrics of intra-subject glucose variability were consistently lower with U300 versus glargine U100. The similar data has also been shown by this other second generation basal insulin, that is insulin degludec. The PD profiles in type 2 diabetes in a steady state is absolutely flat, and I'm not going into details of that because we have discussed about this flatter profile in various other fora. Relative area under the curve in sub time intervals illustrate the consistency of this insulin throughout the 24 hours, and it's exactly peakless and it doesn't peak. So it's again a second generation basal insulin without less glycemic variability. This is the stable 24-hour coverage in type 1 diabetic mean and individual blood glucose profile of insulin degludec. They've also shown lesser inter-individual and inter-individual variability across the 24-hour period in comparison to glargine U100. So these were the two basal insulin generation 2, which has shown a flatter PKPD profile, and they could reduce the glycemic variability and hence more time in range. So comparing generation 2 basal insulin analogs in the light of time in range, so if we can compare these two insulin head on, so there is a nice study we all know, a randomized control trial known as the BRIGHT study, where they have actually compared the glargine 300 versus insulin degludec 100, where they found that in the titration period and in the maintenance period, the A1C reduction have achieved the non-inferiority. But if you see the hypoglycemia incidence, particularly in the titration period in the first 12 weeks, both the confirmed less than 70 or less than 54, it is significantly lower with glargine 300 in comparison to insulin degludec. And the key takeaway message from the BRIGHT study is that they have similar glycemic control, both Glargine 300 and IDEC 100, similar variability in 24-hour SMPG and fasting SMPG. During the full study and maintenance period, anytime and nocturnal confirmed hypoglycemia were comparable, but only during the titration period, the rate of anytime and nocturnal hypoglycemia were lower with Glargine 300 versus insulin degludec 100. But that was about the SMPG study. So let us see about the CGM studies, few of the CGM study which has compared the two insulin, and the time in range has been proven better with which insulin. So this is a new glycemic clamp study, showed lower variability with Glargine 300 versus insulin degludec 100, and this is a clamp study where they have shown that there is a 20% lesser within day variability with Glargine 300 versus insulin degludec 100. And it's an independent PKPD study. This data demonstrated lower variability with Glargine 300 versus insulin degludec. They could show that in comparison to Glargine 300, insulin degludec has got 22% greater peak, and Glargine U300 had 23% lesser variability with Glargine 300. One CGM study comparing the TIR of Glargine 300 versus insulin degludec 100, they've compared the efficacy and safety of Glargine 300 versus insulin degludec on glycemic control using continuous glucose monitoring. And the randomized crossover study with 30 type 2 diabetic patients, once daily Glargine 300 or insulin degludec, and mean percentage of time of TIR has been observed in this CGM study. And what they found was that comparable TIR for Glargine 300 versus IDEC was there, but when they started seeing the time below range, the anytime hypoglycemia, nocturnal hypoglycemia, and severe hypoglycemia in this CGM study has shown a better outcome with Glargine 300, or lesser chances of anytime nocturnal and severe hypoglycemia with Glargine 300 versus insulin degludec. Another study of flask glucose monitoring, TIR of Glargine 300 versus insulin degludec, and this is a randomized crossover study of 24 type 2 diabetic patients in degludec 100 or Glargine 300, and again they have tried to find out the TIR. What they found again was that percentage of time in nocturnal hypoglycemia with Glargine 300 was significantly lower than that with insulin degludec treatment. This is an abstract from ESD 2020, and this is the first time real world evidence in adults type 1 diabetes using CGM Glargine 300 versus insulin degludec 100, and that's otherwise known as the One Care study. This is also a crossover study where adults with type 1 diabetes were switched from first generation basal insulin analog to either to Glargine 300 or to the insulin degludec 100 in both arms, and the CGM data have been collected in 104 patients and 95 patients in both arms. The primary endpoint was the TIR between 70 to 180, and secondary endpoints were TIR and TBR. The result of this study has shown that both the insulin have similar TIR, time above range and time below range profiles between Glargine 300 and insulin degludec 100. But when they compare the night time between 12 AM to 6 AM, the difference in TIR favored Glargine 300 at both 70 to 140 milligram and 70 to 180 milligram per deciliter, and also in time above range. So coming to the conclusion, the key messages are that glycemic variability and deranged time in range are associated with increased risk of severe hypoglycemia, diabetic complication, and reduced quality of life. As TIR is important yet seldom measured, it is recommended to go for treatment solution which take care of TIR even though not regularly monitored. And this is a practical problem also, because many times we don't do CGM or TIR. It's better to give insulin which doesn't produce more glycemic variability. Second generation basal insulin demonstrated improved glycemic variability than other insulin regime. Among second generation basal insulin, Glargine 300 has demonstrated lesser risk of hypoglycemia during the titration period and better time in range profile. So with that, I'll end. Thank you for the patient hearing.
Yeah, very good presentation, Dr. Sambit Das. I think you really went over, the time in range, out of and in the range, hypoglycemia, complications translating to just a 10% variation, bringing a huge variation in the microvascular disease burden of the patient, and how much we overlook all that in our clinical practice, because we don't usually end up in doing the flash glucose monitoring. Neither do we analyze it, nor the patient realizes it, and we don't keep on doing it. If we do it also, that's only for a diagnostic therapeutic measure once in a while to take control or take charge, and how much we are missing out of the whole basket of, and even the known insulins, the degludec and U300 glargine, we usually take it as similar, very very similar, but see, so much of difference is there once you actually read the curves more carefully and analyze it. The smaller differences translating into huge patient outcome, is very, very well highlighted by you, bringing the science of the glucose monitoring to the clinical implications of the complications and the disease burden was very well explained. And I don't have a question particularly, but I would encourage questions from the audience and my co-chairperson and co-speakers as well.
Dr. Sambit, I have one question actually. Do you find that when you use U300, you are having to use a higher dose than the U100 when you switch from U100 to U300?
Yeah, they've actually seen in the pharmacokinetic and PD studies that almost like 12% increase in the dose sometimes is required to achieve the same thing. So in clinical practice, I think they require more, but there are studies which shown that the dose is actually need to be escalated with glargine U300.
Dr. Sambit, do you think we can use SMBG as a poor man's time in range? You can do 4 readings or 5 readings and get some time in range. Dr. Babul showed that, however, that is not very effective. What do you think about SMBG as poor man's time in range?
Yeah, I think we can do SMBG, and at least in a week or week, if we are doing 2 to 3 times reading, at least 2-3 readings in a day, then we get some idea about the glycemic variability and time in range. Even the data which they have dug out from the type 1 diabetes, and where actually the concept of time in range correlating with the microvascular complication has come, is actually retrospective data of the CGM analysis only. The SMBG analysis only. So for poor men, I think SMBG is a good tool to do time in range.
Madam, you can give concluding remarks and we can move on to the next.
Yeah. Any more questions from the audience? No. Usually what I do is just like the GDM patients do. I do like fasting sugar, 2 hours after breakfast, 2 hours after lunch, 2 hours after dinner, in a systematic 4 times in a day, 4 days in a row, consecutive 4 days in a row. And they can, actually take a pic of that and send it to our clinic, to a WhatsApp number or something. And that actually gives a time in range, kind of an idea. And it's because it's a 4 days, 4 times in a day, 4 consecutive days, you kind of cover a bit of what's going on. I think that's a easy something to take home. Like every patient should be encouraged to do that once in a while. And also another column should be there for hypoglycemia. Any low sugar less than 100 with symptoms should be also in that 4th column. With that, we'll close the session. I think because there's no other questions here. It was a very nice session here with Dr. Vijay Bhaskar Reddy taking over from the beginning till the end. I was apologies for my late arrival. The speakers were very, very awesome, and the questions were very, very good. And it was very much of a useful talks to translate into our clinical day-by-day clinical activity, not just a scientific session. Thank you, doctors, for joining us on a Sunday morning. And I'll take leave from here. Thank you. Namaste.
Thank you.
Thank you. Thank you, ma'am. Thanks. We start by inviting Dr. Sridevi. Dr. Sridevi has done her MBBS from Osmania Medical College, Hyderabad. She's a gold medalist in microbiology from there, and she has done her MD and DNB general medicine from Gandhi Medical College. She's a consultant endocrinologist at Apollo Hospital, Secunderabad from 2009 till date. She's assistant professor of endocrinology at Gandhi Medical College, and she has had a special interest in reproductive endocrinology and GDM, and especially type 1 diabetes. She's a visiting consultant in many centers, including a National Institute of Nuclear Fuel Complex, and also Rainbow Hospital, Vikrampuri. We have another eminent endocrinologist as chairperson, Dr. KVS Harikumar. So he has won several awards from the ICMR, and he has the ARC Gold Medal from Endocrine Society of India. He has given the Thyroid Rising Star Oration from the Indian Thyroid Society. He's a young investigator from RSSBI, API, and UPDA. So Dr. Harikumar is a consultant endocrinologist with Magna Centres, Hyderabad. Welcome, sir, and I hand over the session to the chairperson.
Good afternoon, everybody. We are moving absolutely as per schedule, and what best to speak about the impact of COVID. We are doing it virtual, and this is what is the biggest impact of COVID, that we are not meeting all of you physically. So to discuss about the impact of COVID on and the lockdown on diabetes and all other endocrine disorders, we are going to have talk from Dr. Arun. Thanks, Dr. Arun, for joining us. He is a consultant endocrinologist at Tirunelveli, Tamil Nadu. He's done his MBBS from Tamil Nadu and MD from Aligarh and DM from SKIMS Srinagar, and area of interest of adrenals and metabolic bone disease. So he will take us through how the practice has changed in the last year or so, which we have never experienced in the past. So over to Dr. Arun, please.
Okay. Thank you, sir. Thanks for your kind words. I am not able to share my screen, sir. Can you
request Dr. Anand to please stop sharing?
Yeah. Okay. Once again. Yeah, I'm done.
Hope my slide is visible.
No.
Okay. Now, sir?
Yeah, perfect. Go ahead.
Thanks for your kind words, sir. I welcome all my seniors on this eve of Valentine's Day, that too falling on a weekend for an academic discussion, unfortunately. So that too, I'll be talking about the impact of COVID-19 and lockdown on diabetes and other endocrine illness. Has to be one of the washed up topics in last 1 year, along with SGLT2 inhibitors for endocrinologists at least. But still, what I found interesting in this topic was that there are several reviews on this topic over last 1 year. And if we take each one of them and see from the beginning till the latest review, what we could find is that the initial reviews were purely or mostly expert opinions and expert consensus, which has changed over last 1 year to more and more data-driven topic. So that's what I found interesting in this topic. So COVID-19, not only with the endocrinology, moving on, COVID-19, not only with the endocrinology, but also with other aspects of our life, has a bidirectional relationship. What COVID did to us and what we did to COVID with our attitude and practice. So my plan of presentation will go on something like this. The pathogenesis of COVID-19 and possible endocrine links associated with the viral pathogenesis, then what kind of impact that COVID-19 had on patients who had pre-existing diabetes or diabetes overall, and what kind of impact it had on other endocrine illness. So regarding pathogenesis, as with any viral pathogenesis, the virus comes and interacts with the heap of receptors on the cell surface, gets access into the host cell, then utilizes the replicatory mechanism of the host cell and multiply into several virions, eventually lysing the cell, comes out and hits the other cells and goes on like this. So this is common for each and every virus. What is unique between each type of virus is that what kind of protein on the viral surface that interacts with the host and what kind of receptors and co-receptors and the group of it that interacts with that virus. That's what is unique to each virus, and that's what determines its pathogenesis as well as virulence, and how we tackle them also depends on them. So in that regard, the spike protein or the S protein, the beautiful dot-like things which is usually depicted on pics of coronavirus, that actually is the major protein that interacts with the host initially. So with what it binds, the membrane-bound angiotensin converting enzymes, there is a secreted form is separate from the membrane-bound one. So ACE2 binds with the spike protein. This interaction is facilitated by something called as transmembrane serine protein, also known as TMP-RSS2. It is this interaction that aids in the entry of virus into the host cell, which is also facilitated by a protein called furin, which actually helps in engulfing or helps the virus in entering into the cell. So once inside the cell, the pathogenesis is similar, just like any virus. So what this interaction does is that since more and more virus interacts with ACE2, which results in engulfing of ACE2, and eventually ACE2 gets broken down. So there will be an acute shortage of ACE2 on the surface or the host surface. So ACE2 is normally concerned with conversion of a dangerous or a more harmful angiotensin 2 into a more favorable form of agent, angiotensin 1-7 molecule. So it is this deficiency of ACE2 on the surface that drives the pathogenesis of virus after the virus enters into the cell. So when we talk of pathogenesis, actually it can be divided into three stages. Stage 1 is obligatory for all patients who has interaction with COVID virus. So it is the stage of infectivity or the entry of virus into the host. So the degree of expression of the ACE2 receptor as well as the co-receptor that determines whether the virus could enter into the host. So this is common for all in all patients who gets infected with the infection with COVID. But stage 2 and stage 3 differs from individual to individual. Stage 2, our HLA genotype could predispose to this stage of inflammation. So in this stage, what drives the inflammation is that there is an acute shortage of ACE2 on the surface, as well as because of the shortage of ACE2, there exists an overexpression of angiotensin 2 as well as its receptor, as well as then underexpression of a more favorable agent, that is angiotensin 1-7 molecule and its receptor. So from stage 2, what constitutes stage 3 is the most dangerous one, the stage in which the multi-organ dysfunction sets in. So it is the variation in stage 2 that determines whether we move on to stage 3 or we recover from the virus. So in short, if we talk about the viral pathogenesis, ACE2 is a molecule that can be considered as both a hero and a villain at the same time. I don't know how many of you could get the pic or the impression from this pic. So, but I would like to highlight this point. So the other one is that when we think of from the immunity point of view, it is the defective innate immunity that aids initially in entry of virus into the host cell. But once it gets inside, it is the delayed arrival as well as a dysregulated arrival of adaptive immunity that drives the further course of the virus. These are the 2 points I would like to highlight in viral pathogenesis. So what are the endocrine links in this viral pathogenesis? There are 3 major things. One is that there is overexpression of the renin, angiotensin, aldosterone axis, which is one of the key pathway, endocrine pathway. The other one, the co-receptor, transmembrane serine protein co-receptor, is purely androgen dependent or is mostly androgen dependent. So that could explain the higher mortality or the higher rate of virulence in men compared to women. So other than these two, it's also seen in several trials, mainly in vitro trials, that DPP, also known as the CD26, can also act as a portal of entry or a receptor for the viral entry. How much of it is true or how much of it is clinically relevant is not known as of now. So moving on, we'll be talking the both ways, what COVID-19 did to those with diabetes patients, those with already having diabetes, and what dysglycemia that occurred due to COVID-19 impacted its course. So when we talk of pathogenesis in patients with pre-existing diabetes or having poor glycemic control, they have increased expression of ACE2. So they may be at risk of more at risk of contracting COVID virus. And once they contract the virus, they have impaired innate immunity. Their NK cell, their lazy leukocytes, because of all the glycemia-induced damages, impair the innate immunity, as well as the adaptive immunity is also defective, and they progress in an unregulated manner. So this is the impact of diabetes on SARS-CoV-2, whether diabetic patients are at increased risk for SARS-CoV-2. We do not know as of now, but they definitely have worse outcome once the infection gets established. Partly, the various pathogenesis that could attribute to this worse outcome, I have already discussed. One more thing I would like to highlight. In presence of poor glycemic control, there will be more and more glycosylation of viral protein as well as increased furin expression that kind of increases the virulence of the virus. So to put in some numbers, starting from the earlier hit zone, the Wuhan, nearly 20% of positive cases were already having diabetes, and 7.1% of ICU admissions, ICU admission patients were already having diabetes. Then the data from US was even more grave. Nearly 58% of ICU admissions, the patients had diabetes, any form of diabetes. And also, it was shown in few studies that nearly there exists a 4 times higher risk of hospitalization in those who have diabetes. That includes both type 1 and type 2, and also they carry nearly 3 times the higher risk for suffering from severe disease. So we know poor glycemic control impacts the severity of COVID. So what about when we achieve glycemic control, whether there will be reduction in severity? Some studies have looked into that. Irrespective of the presence of diabetes, it's the higher fasting plasma glucose at admission that predicted mortality in a study from China. And also those who continues to have poor glycemic control during admission, they carried much higher mortality compared to those who had euglycemic, those who remain euglycemic throughout admission. And also those with hyperglycemia with a cutoff of more than 140 was shown in a study to have higher levels of cytokines at admission, irrespective of whether they had the diabetes were detected after admission or prior to admission. And also it was shown that compared to diabetic patient who did not receive insulin, those who received insulin infusion and had reasonable glycemic control suffered from less severe disease. So what about the direct impact of COVID-19 on glucose homeostasis? There were several reports of new onset diabetes of both kinds, type 1 as well as type 2, after or during course of COVID-19. There is even an international registry named COVID-Diab that is looking into that. Then also those who had pre-existing diabetes with good glycemic control, they also suffered from worsening of glycemic control, either it is because of direct impact of the virus or because of the steroid use, rampant steroid use. They had worsening of glycemic control. DKA, precipitation of DKA in type 1 is well known with any viral illness, but it was shown, it was unique to COVID that many patients with type 2 also suffered from DKA after suffering from COVID. And also patients with COVID usually show an unusually higher insulin requirement. So what aids these defects is probably an indirect response from the higher or exaggerated inflammatory response or a cytokine response seen in COVID that worsens insulin resistance. And also it is possible, quite possible at this time, we have only hypothesis that it's quite possible that that COVID or the SARS-CoV-2 causes a direct cytopathic injury to the beta cell. It was shown in post-mortem studies that those who died from SARS-CoV-2, it was shown that in the whole of pancreas, it's actually the ACE2 is overexpressed in islet, and even within islets, it's only the beta cell that shows more expression of ACE2 compared to the alpha cell. Compared to a normal cadaveric studies, which have shown that ACE2 is present throughout the pancreatic parenchyma. So whether COVID modulates this distribution of ACE2 from a diffuse from throughout pancreas to whether it restricts the expression of ACE2 to the beta cell or not, it's not known as of now. Apart from that, immune-mediated beta cell damage is also possible after suffering from COVID, theoretically at least as of now. And also pancreatic injury can also occur as a systemic response to acute respiratory failure. So these are the hypotheses that we have as of now. So COVID-associated dysglycemia, when we look closely into the available data, There are several reports of new onset diabetes, but whether it will be transient or whether it will be long lasting is not known as of now. We'll have to wait and see. Whether there is an actual increase in incidence of diabetes, especially type 1 diabetes mellitus after the onset of COVID pandemic, is also awaited. We do not know as of now. We need more data. And it's also seen that even in a non-diabetic individual, there is increased predisposition for developing ketosis after contracting COVID. And in a systemic review, it was shown that nearly 77% of total admission with DKA was seen in those with type 2 diabetes mellitus, which is quite unusual. So regarding what are the glycemic effect of potential COVID therapies, glucocorticoids as well as the antiviral agents, this lopinavir or the ritonavir, they have definite dysglycemic effect, while all the other agents that predominantly target cytokine response, they have favorable glycemic profile. So what about the treatment consideration that we should have while treating a patient with diabetes and COVID? There are several anti-diabetic agents that increases the expression of ACE2 levels. To mention few, thiazolidinediones are notorious, as are a GLP-1 analog, SGLT2 inhibitor, and even insulin was shown in several studies that they increases the level of ACE2. So as I told earlier, this increased expression will translate into a worse outcome or a beneficial outcome. We do not know as of now. Among the available agents, thiazolidinediones, SGLT2 inhibitor, because of its inherent tendency, they cannot be given, or they are definitely harmful in those who have severe COVID. Thiazolidinediones, we know in any case of organ failure, they predispose the patient to developing heart failure. SGLT2 inhibitor, on the other hand, when we use in sick patients, there is a high risk of suffering from DKA. Then potentially, there are some diabetic agents that has some potential therapeutic effect on COVID. They include insulin, metformin, as we all know, have some anti-inflammatory effects, so they might have some beneficial effect in those suffering from COVID. As a DPP4 inhibitor, as I told earlier, DPP is one of the receptor that has been hypothesized to get involved in COVID pathogenesis. So inhibiting that with the DPP4 inhibitor may be beneficial. We do not know for sure as of now. So this is a mere expert consensus taken from a review published in Nature a few months back. So what they say, in a hospitalized patient with a severe disease, insulin and probably DPP4 inhibitors are safe, and other agents are either they have to be avoided or used with caution. So moving on. So then what about the effect of lockdown on a diabetes care? So these studies are actually upcoming studies. So there are two different kind of studies. One from the European countries, wherever they have published the report, they have used CGMS data, while data from the developing countries are mostly based on either a questionnaire or a few blood glucose readings or direct home visits or something like that. So the common dictum is that whatever European studies published from Spain, Italy, or France, they have shown that despite the reduction in physical activity, there was a significant increase in time in range, as well as improvement in glucose management index, along with concomitant fall in time above range as well as time below range. While on the other hand, studies from developing countries have shown that there is a worsening of glycemic control with more episodes of hyper as well as hypoglycemia in those who have pre-existing diabetes, with significant worsening of mean HbA1c during time of lockdown, as well as because of frequent missing of insulin doses, more and more patients landed in trouble, and frequency of SMPG also went down. So to put in simple words, what kind of effect the lockdown had on diabetes care, we could say that similar effect was also seen in our economy because of COVID. Those who received better care prior to the onset of COVID, they actually did much better even during lockdown. While in those countries where the diabetes care was already strained, they fared really poor. They fared really poorly. So you could say that rich got richer and the poor got poorer. That was the kind of impact that COVID-induced lockdown had on diabetes care. Evidences showing involvement of COVID-19 and other endocrine illness are far and few. So most of the lessons or most of the hypotheses have arrived from our experience with previous coronavirus pandemic, one in 2002 and 9. So in previous coronavirus-induced pandemic, it was shown that nearly 3 months after the patient recovered from COVID, not COVID, the SARS-CoV-1, they had persistent central hypocortisolism as well as central hypothyroidism. And during while suffering during the acute episode, it was also shown that they had increased levels of prolactin, FSH, and LH, along with reduction in TSH. And pituitary autopsy from those patients have also showed similar distribution of cells, pituitary cells. So the pathogenesis that was advocated earlier was probably direct ACE2 mediated entry of SARS-CoV-1 into hypothalamus as well as pituitary. And other one was cytokine mediated inflammation that led to hypophysitis. And third interesting point that was seen with earlier coronavirus pandemic was that people actually developed anti-ACTH antibody after recovering from the virus. So these are the lessons that we had from earlier pandemic. So coming to COVID, there is a possibility that similar involvement may be seen, but as of now, not much has been reported. We need long-term studies. I would like to highlight two hypotheses. Cytokine storm is so common in COVID, and we know interleukin-6 is the major mediator. It has been hypothesized that probably the high level of interleukin-6 in COVID-19 affected mothers might cause suppression of IGF-1, thereby predisposing risk of autism in those children born to those mothers. So this hypothesis needs long-term validation. And also, it is interesting to note that the growth hormone IGF-1 system as well as the cytokine storm is mediated by the common second messenger, that is STAT messenger. Here it is the STAT5 that is the major mediator in growth hormone IGF-1 axis, while cytokine storm, the STAT3 is the major mediator. How these interaction has a significance, health significance, it's not known as of now. So there's one more hypothesis based on earlier coronavirus, that this post-viral fatigue syndrome, which is usually seen with any viral infection and also more prominent with COVID infection, it may be associated with hypocortisolism, which may or may not be because of the steroid use during treatment of COVID-19. And there are some reports of dramatic improvement with steroid therapy in post-viral fatigue syndrome during earlier pandemics. So this hypothesis needs further study. Then those who have pre-existing pituitary condition, they were very much prone for developing dysarthrolemia as well as dehydration because of the fever as well as the associated associated cytokine storm. So because of the RAS overactivation, there was a peculiar or a high risk of, atypically high risk of hypokalemia in those with COVID compared to other illnesses. Especially patients with pre-existing diabetes insipidus, they were more prone for dysarthrolemia. The major dictum that has to be followed in those patients is to avoid hyponatremia. And based on expert consensus, it was advocated that possibly drug holiday needs to be given in those patients regularly. Other replacement therapy should continue as before. Probably in those with COVID-related hospitalization, it's prudent to avoid growth hormone injection. Patients who are on bromocriptine, especially, we have to be aware of drug interaction, especially while using lopinavir and ritonavir. So these are mainly based on expert consensus. We are awaiting more studies regarding this. Regarding COVID and infection of thyroid, sick euthyroid syndrome is quite common. We all know that. And there are several reports of post-COVID atypical subacute thyroiditis. Whether it's an incidental finding or a mere or a direct causative relationship is there, we do not know as of now. Most of these patients are negative for thyroid antibodies. So the authors, especially the Mueller et al., have proposed that probably cell-mediated thyroid damage induced this post-COVID thyroiditis. So one more point I would like to highlight is that postmortem studies that looked into thyroid specimen from earlier coronavirus pandemic compared to COVID-19. There was a clear-cut difference. So SARS-CoV-1 induced thyroid damage while studied in postmortem samples have shown that predominantly follicle and parafollicle cells were damaged. Inflammatory infiltrates were limited. But SARS-CoV-2, on the other hand, there was no follicular damage, but lymphocytic infiltrates are predominant. So it's quite possible that the thyroid damage, whatever is seen with COVID, is mainly mediated by cell-mediated tissue injury and not mediated by antibodies. So PCR studies have shown that SARS-CoV-2 is expressed in thyroid gland as well. Then COVID and adrenal issues. So as of now, no direct reports of adrenal involvement in COVID. But it's quite possible that those who suffer from cytokine storm have strong stimulation of adrenals, and there lies a risk of hemorrhage, adrenal hemorrhage, and eventual primary adrenal insufficiency in them. Adrenals also express ACE2, so possibly direct injury is possible in them. So what about steroid therapy in COVID? It's actually the raging therapy. Everybody has started using that after recovery trial. Actually, recovery trial compared to the earlier analysis have shown, surprisingly showed that in those ventilated patients as well as those who are on oxygen, there was a significant reduction in mortality. So possible benefit, how steroid produce benefits in COVID patient is that they suppress inflammation during cytokine storm, as well as they have a possible membrane stabilizing effect. There is also some hypothesis that possibly patient with COVID have some adrenal insufficiency and steroid might help them. And on the other hand, the drawbacks produced by steroid therapy is that there is protracted viral shedding, especially when steroid is used early in the course. And from an endocrine perspective, actually, there is long-term risk of HPA suppression as well as dysglycemia. So probably timing is critical. Probably steroid produces effect when used late in the course rather than early in the course. When used early in the course, probably it may be more harmful. So regarding cortisol response in COVID, this is a good study published by Tan et al., which showed that most of COVID-19 patient produces brisk cortisol response. So there is no query of steroid benefit because of correction of adrenal insufficiency. In fact, the baseline cortisol levels were highly predictive of mortality in their study, with a cutoff of 27 microgram per deciliter. So beneficial effect of steroid is probably unrelated to the presence of adrenal insufficiency in those who suffered from COVID. So in those with pre-existing adrenal insufficiency, they are usually at risk of catching any infection. So probably they are at increased risk of catching COVID as well. Whether they run a severe course or not, we do not know as of now, but they definitely run a risk of precipitating adrenal crisis. So what is important is to note that the standard guideline, that is increasing or doubling the dose of steroid with the onset of febrile illness, may not work as per the experts who are dealt with these things. They may not work in COVID-19. So at the onset of illness, it is recommended that probably the morning dose of hydrocortisone needs to be doubled, followed by 20 milligram of hydrocortisone 6 hourly. And parenteral therapy needs to be considered at the earliest. Fludrocortisone usually do not require dose adjustment. So one point to note is that dexamethasone has no medulocorticoid activity. Everybody knows that. Why I highlighted this is that usually when hospitalized patient is started on dexamethasone, there is a tendency to stop earlier treatment for adrenal insufficiency. So when using dexamethasone, the fludrocortisone needs to be continued. That needs to be kept in mind. So in Cushing syndrome patient, probably with COVID-19 infection, they might carry poor prognosis. There is a risk of superbacterial infection in them. Coagulopathy unique to COVID-19 may get aggravated in them. And as I told earlier, the hypokalemia associated with COVID-19 may be more severe in those with pre-existing Cushing syndrome. So low molecular weight heparin and aggressive correction of potassium are major consideration. So COVID and gonads, it was shown in several studies that ACE2, the major receptor of COVID, is highly expressed in testes, but not in ovaries. So there is a possibility that testis might act as a viral reservoir. And so SARS-CoV-2 was also found in semen samples. So whether COVID can be considered as a sexually transmitted disease, we do not know as of now. Whether COVID infection could lead to long-term infertility is also not known. We need more data. And it was shown in some studies that low testosterone and an increased LH was seen during admission with COVID-19. Whether it's because of adaptive response or a long-term testicular damage is not known. So this is a famous paper, observational study from Italy, that showed that males compared to female develop more severe complication, were more frequently hospitalized and had worse outcome. And also they threw an interesting finding that prostate cancer patient among COVID-19 patient who had pre-existing prostate cancer, those who received androgen deprivation therapy had lower risk of SARS-CoV-2 infection compared to those who did not receive. So this actually concurred with the epidemiological studies that showed that men suffered from worse outcome compared to women. So possible hypotheses include this transmembrane protein, serine protease, is actually androgen dependent, as I told earlier. So probably the increased expression of TMPRSS2 might predispose male for worse outcome compared to women. As well as ACE2 gene is located in X chromosome. So X chromosome inactivation and paternal imprinting in women might probably be protective against COVID-19. So regarding obesity, almost universally, all studies have shown poor outcome in patients with obese who contract COVID-19. Study from China showed that nearly 142% higher risk of developing severe pneumonia in patients with COVID. And a study from US showed that apart from elderly age, BMI more than 40 is one of the strongest predictor of hospitalization. So mechanism-wise, how COVID and obesity is linked is that the respiratory reserve is low in patient with obesity. So that might predispose them to acute lung injury, and accompanying comorbidities might make the case worsen in them. And probably because of immune dysregulation, viral shedding and viral load might probably be more in patients with obesity compared to others. And
sorry for
as we all
interrupting, Dr. Arun. The time is exceeding, so I think you can conclude the talk with summary.
Yeah. I don't have much of a summary. My closing remarks is that a wartime expediency statement from, I would like to quote a wartime expediency state from Professor Watts. During onset of World War I, he told that give them the third bus because second bus is too slow and probably the best never arrives. This expediency has been realized worldwide by the medical fraternity. And probably in our country, we are already working with the third bus before the arrival of pandemic. Probably our situation has worsened. So that's what I believe. So thank you.
Thank you, Dr. Arun. Sorry for interrupting, but actually we were maintaining the schedule. That was an excellent talk. You have covered all the points, I mean, including all the endocrine glands. That was really very good. And yeah, most of us have seen in our personal experience, especially in our country like ours, where self-monitoring and all is not done frequently. In my clinical practice, I've seen most of the patients' sugars worsening with the onset of lockdown and lack of physical activity. Even whatever little physical activity has come to a halt, sitting home and maybe increased food intake because of no other work. All this led to poor glycemic control in already established diabetic patients. And we are seeing also new onset diabetes patients in COVID. And other point which I wanted to highlight is that, the patients who are on steroids, some patients are receiving a prolonged course of steroid and they'll be tapered, and actually they will not be properly counseled about the adjustment of the doses of insulin or oral hypoglycemic agents when they're discharged, and people landing up in hypoglycemias, and all these also have become very common. So it's very important to take a careful history of how many days the patient has received the steroid, if they can at all tell, and then ask them to monitor, encourage self-monitoring. I think telemedicine, which was started because of this lockdown, at least in some of my patients, self-monitoring, they understood the importance and started doing it. So it gave an opportunity to patients to, know their sugars better in some educated patients, but otherwise it has gone for a toss in most of the patients. Thank you very much for the excellent talk. So we'll move to the next session. So
request Dr. Arun to stop sharing his screen so that.
Yeah. So now I welcome Dr. Datta Reddy. He is actually from Hyderabad, who has done his DM, both MBBS, MD, and also DM endocrinology from Osmania Medical College. And he's one of the youngest endocrinologists now, budding endocrinologist, I would say, in Hyderabad. And presently he's working as a consultant endocrinologist at Yashoda Hospital, Malakpet. So I asked Dr. Datta Reddy to take out the proceedings. Thank you.
Can you see my slides now?
Yeah.
Yes.
Yeah. So first of all, my sincere thanks to Team Magna for giving me this opportunity to discuss about one of the most important and one of the common issues in the population. But I think it is one of the less commonly discussed issue, that is iodine deficiency, and how to prevent the iodine deficiency with the iodine salt. So we know that iodine deficiency disorders are one of the common clinical entity at the patient level, community level, as well as country level also. And iodine is one of the most important micronutrient which is involved in the synthesis of thyroid hormones. And thyroid hormones are mainly involved in the cell growth, differentiation, and metabolism. Every tissue in the body have thyroid hormones, and abnormal thyroid hormone levels significantly alter the metabolism. So, and I'll start the discussion with the discovery of iodine. So iodine was actually discovered accidentally. So in the early 1800s, the French was at war. So to supply the gunpowder, So the French chemist, that is Bernard, so tried to extract the sodium carbonate from the seaweed ash. So after burning the seaweeds, so his copper vessels were severely corrosed. So to clean those copper vessels, he was trying to clean those vessels with the sulfuric acid. After pouring the sulfuric acid to those metal vessels, so there was an intense violet colored vapor was produced. So after cooling it, it was giving a violet colored crystals. He don't know what was those new material, and he sent those crystals to his friend. It is one of the French chemist, Gay Lussac. So he was subsequently identified it as a new element. So that was the discovery of iodine. So and he named that new material as iodine. So the term is from the Greek for the violet. So the thyroid disorders are known since ages, but the treatment of thyroid disorders, I think, by the ancient Greeks used to treat the swollen glands with the marine sponge, and Italian physicians were the first to report the specific uses of the sponge and dry seaweed that treat the swollen thyroid, that is goiter. And after that, the sponge remained the cure of goiter, and it was one of the treatment armamentarium for the treatment of goiter through the Middle Ages and even into the modern era also. But it was after the discovery of iodine in 1819, Straub demonstrated sponges were rich in the iodine. And in 1813, the Switzerland physician Kaindet hypothesized that the traditional treatment of goiter in the ancient used by ancient physicians were due to the by the seaweed was due to the effect of iodine in that seaweed. So which was that was the confirmation of the iodine which is used to treat the goiter or thyroid swelling. And most of the development of the thyroid disorders comes from the Western Europe countries, because Western Europe countries one of the severely iodine deficient areas due to the Alps in those areas. And the French chemist Boussingault was the first to advocate prophylaxis with iodine salt to prevent goiter. So his observations, he noticed that so when the persons when he sent the salt from the iodine free areas to the iodine deficient areas, so there was a significant reduction in the goiter prevalence was there. It was his first observation. And the Rowlin, who was co-worker of the Boussingault, so he noticed that young people who are emigrated from the iodine deficient areas to the iodine sufficient areas, so there was a significant reduction of the goiter was there. And similarly, though the people who are from the iodine deficient areas who immigrate to the iodine, people from the iodine deficient areas, the iodine sufficient areas who immigrate to the iodine deficient areas. So within 5 to 6 years, there was a significant increase in the goiter was there. So this, which is their initial observation, and they are recommended or advocated prophylaxis iodine salt to prevent the goiter. And the French chemist Chartin was the first to publish in 1851 the hypothesis that iodine deficiency was the cause of goiter, and iodine replacement with the salt was the cure for the or prophylaxis of the goiter. So we know that iodine is the essential element in the thyroid hormones, and from the plasma, iodine is extracted to the thyroid follicular cells by the help of the sodium iodide symporter. And from the thyroid follicular cell, iodine enters into the follicular lumen by the help of the pendrin and one more molecule. In the follicular lumen, iodine is oxidized to iodide, so with the help of thyroid peroxidase and the hydrogen peroxidase. And this is called oxidation. After the oxidation of iodine, which binds with the specific tyrosyl residues in the thyroglobulin molecule. So that is called organification or iodification, and which leads to the production of monoiodotyrosine and diiodotyrosine. During the coupling reaction, which is also helped by the thyroid peroxidase, so combination of monoiodotyrosine and diiodotyrosine lead to the production of triiodothyronine, and two DIT molecules combine or coupled to form the thyroxine. And after the synthesis of thyroxine in the thyroid hormones in the follicular lumen are colloid, so these thyroglobulin molecules are entered into the follicular thyroid epithelial cell, so by the endocytosis, and after that it was hydrolyzed to release the T3 and T4, and these thyroid hormones enters into the circulation by the help of MCT8. So this is the cycle of the thyroid hormone synthesis. And thyroid, the majority of the the iodine comes to the human body from the environment, or soil, or food. And the iodine is vast and widely distributed in the environment, but which is not uniform. The major source of iodine in the environment is the seawater, so which contains almost 50 micrograms of iodine per liter of seawater. And animals as well as sea plants or marine plants are very rich in the iodine. So due to the vaporization, so the iodine enters into the atmosphere, and from the rain, this iodine comes to the soil. But this cycle is not uniform throughout the Earth's surface. And due to the repeated floods or repeated glaciation or repeated leaching, so the iodine is iodine level of the soil significantly reduced in the hilly areas. So that leads to the reduced amount of iodine in the water, as well as reduced amount of iodine in the plant which grows in those iodine deficient areas. That leads to the iodine deficiency in the humans. And the native iodine content of the most foods and beverages are very, very low, and which depending upon the foods, which gives almost 3 to 80 micrograms of iodine per serving. But majority of the iodine comes from the marine origin food. So, and the sea salt, which is commonly used in previously, so which contains very negligible amount of iodine due to the evaporation of the iodine by the sun exposure. And in the industrial countries, the majority of the dietary sources comes from the bread and milk, which are fortified with the iodine salt or iodine. And in the other countries, the major source of dietary iodine comes from the iodine salt, which is used for the cooking. And interestingly, boiling or baking significantly reduce the iodine component of the salt very minimal. That is, the loss of the iodine is less than 10%. So once iodine is rapidly absorbed from the proximal intestine, whether from the stomach as well as duodenum, more than 90% of the ingested iodine is absorbed. And most of the iodine is absorbed passively, but some amount of iodine is absorbed actively through the sodium iodide symporter as well as the sodium multivitamin transporter. And rapidly after entering into the plasma, iodine is cleared mainly by the thyroid. Majority, more than 80% of the iodine is extracted by the thyroid, and remaining iodine is excreted by the kidney. And it has a plasma half-life of 10 hours. And the body contains around 20 milligrams of iodine, and majority, almost 80%, is in the thyroid gland itself. And after the recycling of the iodine, so more than 90% of the ingested iodine is ultimately excreted in the urine. That is the reason urine iodine concentration is one of the important marker of the iodine status of the population. And the goiter is not only due to the iodine deficiency. There are some aggravating or precipitating factors which increase the risk of goiter in the endemic iodine deficiency areas. Those are called goitrogens. So goitrogens can be naturally occurring products, or it can be environmental pollutants. But it is clinically relevant only if the dietary iodine supply is very low or very limited, or the goitrogen intake is significantly high and which is prolonged. Then only these goitrogens leads to the development of goiter. There are various chemicals, simply we can call it as endocrine disruptors, which causes the increase the risk of goiter. So like sulfurated organics like thiocyanates, flavonoids, and organochlorines, even lithium also can lead to the increased risk of goiter. So the effect is at different levels. So some chemicals and those metabolites compete with the sodium iodide symporter of entry into the thyroid. Some directly damages the thyroid peroxidase. Some reduce the release of thyroid hormones from thyroid gland. So there are various mechanisms which increase the risk of goiter. And similarly, some dietary products also can cause goiter, especially the cruciferous vegetables like cauliflower, cabbage, and broccoli. So these foods contains glucose enolates. So these metabolites compete with the iodine symporter for the entry of the iodine into the thyroid follicular cells. That leads to increased risk of goiter. And some cassava beans, some linseed, and sweet potato also have some amount of cyanogenic glucosides, which increase the risk of goiter. And even soya and millet also, those flavonoids which is there in those products also damages or impair thyroid peroxidase activity, and these things increase the risk of goiter. And interestingly, some even mineral deficiency and some vitamin deficiencies also aggravate the risk of goiter, especially the selenium deficiency. Selenium is one of the common molecule, so which is present in glutathione peroxidase, and selenium deficiency increases the production of peroxidase, which directly damages the thyroid follicular cells. And even selenium is important component in the deiodinase enzyme. So this deiodinase enzyme reduces the thyroid hormone conversion as well as synthesis also. And interestingly, iodine deficiency increases the goiter risk. So that is due to the reduced effect of heme-dependent thyroperoxidase activity. That is the reason in the areas of endemic goiter, so we need to replace the iron also, because iron deficiency anemia blunts the effectiveness of the iodine prophylaxis. So that is the reason the dual replacement of iron as well as iodine improve the effectiveness of iodine salt and reduce the risk of goiter. And vitamin A deficiency also increase the TSH stimulation and increase the risk of goiter. That is through the decreased vitamin A mediated suppression of the pituitary TSH beta gene. So there are various reasons for the endemic goiter, that is iron deficiency, as well as some goitrogens, as well as mineral and associated mineral and vitamin deficiency also is risk of goiter. And what is the recommended daily iodine intake? So there are two different recommendations from the US Institute of Medicine and World Health Organization. And the children between 0 to 5 years, the recommended daily requirement of iodine is the 90 microgram per day. And children more than 6 to 12 years, it is 120 micrograms per day. And adults, 150 micrograms per day requirement of iodine is recommended. And during the pregnancy and lactation, the recommended iodine intake per day is the 250 micrograms per day. And what about the global scenario of the iodine status? So iodine deficiency can be measured at the population level by the measuring the urine iodine concentration in school-aged children. So if the urine iodine concentration is less than 20 microgram per liter, that is called severe iodine deficiency. And the optimal iodine intake is in between 100 to 300 microgram per liter of urine iodine excretion. And most of the studies are now iodine sufficient. And some even still after almost 50 to 100 years of salt application also, and some countries still have iodine deficiency. And here is the Indian status. So this is a report of the 2018 to 19 Indian iodine survey. So which looked at those they had done the household survey, how many percentage of the households consuming the iodized salt. So the effective universal salt iodization, we can call it as effective only if the more than 90% of the households consume iodine salt, which contains more than 15 ppm of iodine in that salt. So in our country, and still most of the states so consumes only less than 7 consume iodized salt. Only some states consume more than 90% of the iodine. 90% of the households consume iodized salt. Still, some states are lag behind those states. And coming to the iodine deficiency disorders, so we know that thyroid hormone affects on almost every tissue or organ, and which involved in the cell growth and development and metabolism. And the iodine deficiency is the iodine deficiency increases the risk of thyroid disorders, and there is a vast spectrum of thyroid disorders. These disorders which are due to the iodine deficiency is called iodine deficiency disorders, and these are the most important and common human disease, and which is still, even after 100 years of salt iodization, which continues to be a public health problem. And fortunately, it is the easiest major nutritional deficiencies to correct, and which is it is also one of the most prevalent cause of preventable mental retardation. And there is a vast spectrum of iodine deficiency disorder. It can affect the fetus from the fetus to the elderly age also. So in the fetus, the maternal severe hypothyroxemia lead to the increased risk of abortion, which can cause stillbirths and congenital anomalies, and increase the risk of fetal goiter and perinatal mortality and morbidity also. And more importantly, or more significant problem is the cretinism is one of the important problem with the iodine deficiency during the gestation. And it can affect the neonate, which can cause neonatal goiter and neonatal hypothyroidism. And in the pediatric age group, it can cause juvenile hypothyroidism. And importantly, it can affect the mental development as well as the physical growth and sexual maturation also. In the adults, it can cause goiter, and goiter itself is has their own complications, and it can cause hypothyroidism as well as iodine-induced hyperthyroidism also. So these are the spectrum of iodine deficiency disorders across the lifespan. And what happens if the iodine is deficient? So there is a thyroid try to compensate the iodine deficiency. So if the iodine intake falls below the 100 microgram per day, so the initial response of the thyroid follicular cell is there is a stimulation of the thyroid. TSH hormone will be stimulated. The augmentation of TSH will be there. This increased TSH stimulate the sodium iodide symporter. This NAS try to extract high amount of iodine which is available in the plasma to the thyroid follicular cell, which increases the production of thyroid hormones. But if the thyroid iodine deficiency is prolonged and severe, if it is leads to less than 60 microgram per day, so despite of increased extraction of the iodine from the plasma, so the iodine deficiency will occur, the thyroid hormone production will be depleted, and there is a risk of development of the goiter. And usually the endemic goiter is leads to the diffuse enlargement of the goiter, which is homogeneous. But over the time, there is an increased risk of nodularity. So, and some patients may develop multinodular goiter. And importantly, most nodules comes from the somatic mutations and are of monoclonal in origin. And initially, histopathology shows that there is a significant hyperplasia with abundant parenchyma and high follicular epithelium. But over the course of time, if it is chronic, so there is an involution and atrophy of the thyroid follicular cells will be there. And how to assess the iodine nutritional status in the population? So there are 4 recommended methods to know the iodine nutritional status of the population. One is most sensitive and most important is the urine iodine concentration, and other things are goiter rate in the school age children, and TSH value, and thyroglobulin. And the urine iodine concentration is the immediate which shows the recent past iodine nutrition status, but over the weeks to months, then only we can detect the goiter as well as thyroglobulin. So one of the most important thing in the iodine deficiency is the iodine deficiency in the pregnancy. So because initial during the first trimester, before the production of thyroid hormones from the fetus, thyroid hormones comes from the mother to the fetus only. So during that period, if the mother is having severe hypothyroxemia, so there is a significant defect in the cellular differentiation as well as gene expression will be there. So more importantly, brain development significantly affects if the mother is having severe iodine deficiency and severe hypothyroxemia. So here there are 2 phases of the brain development. So brain develops fully by the 2 to 3 years of age. During the during the initial stage of development of the fetus. So after the 8 to 16 or 20 weeks, there is a period of rapid growth or development of brain. So that is due to the neurogenesis and multiplication of the neuronal cells. So during that period, if the iodine deficiency is significant, that significantly affect the development of the brain. And after the 2nd or 3rd trimester, so there is the second phase of the rapid development of the brain till it which sustains to the up to the 2 to 3 years of the age. So during that period also, there is a glial cell multiplication and migration and myelination will be there. During that period also, we need to give the adequate iodine nutrition, or else there is increased risk of defect in the neurological development. And most severe manifestation of the iodine deficiency during the pregnancy is the cretinism. So that the term cretin was first used in the Diderot's encyclopedia in 1754. So he described cretin as an imbecile who is deaf and dumb with a goiter hanging down to the waist. And in northern India, McCarrison identified the 2 different forms of cretinism, that is neurological form as well as mixed edematous form. So there are 3 major features of endemic cretinism. So which it should occurs in the iodine deficiency area or endemic area. And there are 2 types of clinical manifestations. either or in combination. Like one is neurological form, that is neurological cretinism, then when predominates the hypothyroidism and stunted growth, that is called myxedematous cretinism, and it should be prevented or corrected with the iodine replacement. So this is the definition of endemic cretinism. And the neurological cretinism is one of the most dangerous form or most important form. So there are three classical features, so which is severe mental retardation with the squint, and deaf mutism will be there, and motor spasticity of the both upper and lower limbs will be there. And the deaf mutism is due to the underdevelopment of cochlea, and due to the underdevelopment or maldevelopment of cerebral neocortex lead to the mental retardation, and maldevelopment of the corpus striatum lead to the spasticity of the or motor abnormalities. And interestingly, cerebellum and hypothalamus as visual system is unaffected. In those patients with the neurological cretinism, abstract thinking is significantly affected, but the memory may be normal in the neurological cretinism patients. And other form is the myxedematous cretinism, so which is less severe than the mental, which contains less severe mental retardation, but all other features of severe hypothyroidism is there. So which is similar to the congenital or juvenile hypothyroidism. Like severe stunted growth will be there, puffiness of the face will be there, incomplete maturation of the face and nasolabial fold will be there, and myxedema will be there, dry skin will be there, and there is a delayed maturation of the sexual maturation will be there. These are the classical symptoms of features of myxedematous cretinism. And interestingly, the goiter may be absent in the myxedematous cretinism due to the atrophy of the thyroid gland. So there are the comparative features of the neurological cretinism and myxedematous cretinism. So more neurological features will be there in the neurological cretinism, which may be absent in the myxedematous cretinism. In myxedematous cretinism, the more hypothyroidism features will be there. And importantly, if you replace the replacement of the thyroid hormones will not affect the neurological cretinism, but the symptoms will be recovered or improved with the replacement of the thyroid hormones in the myxedematous cretinism patients. And in the adults, the risk of goiter will be there, and there is a high risk of development of nodules, as well as there may be a chance of the development of thyroid cancer in the chronic endemic goiter. So here is one review of the literature. So they showed that there is a chronic iodine deficiency is one of the important risk factors for the development of thyroid cancer. And the type of thyroid cancer which increases in the iodine deficiency region is the follicular thyroid cancer, and there is a risk of anaplastic cancer, increased risk also will be there with the iodine deficiency. And this study showed that the replacement of iodine can reduce the risk of goiter as well as the risk of thyroid cancer morbidity. Even mortality of thyroid cancer is also reduced with the high amount of iodine intake. But some studies did not show the relation between the iodine intake and thyroid cancer development. And one of the important preventive measure for the iodine deficiency is the salt fortification with the iodine, because which is one of the most effective method of control of the iodine deficiency. Why the salt is commonly used as the recommended method of salt iodine fortification is because every human being consumes some amount of salt, and interestingly, the amount of salt consumption is similar, consistent throughout the year. There is no difference in the according to the seasons. And in many countries, salt production and importation is done by few sources only. And iodization technology is very simple and relatively inexpensive. And more importantly, the addition of iodine to the salt does not change its, does not affect its color as well as taste also. So which is palatable. And the quantity of iodine in a salt is simply you can monitor from the production to the retail shops as well as from the households also. And the WHO and UNICEF recommends that iodine should be added at the level of manufacturing. 20 to 40 milligrams of iodine per kg should be added. And iodine can be added by the two things, like the potassium iodide or potassium iodate. Can be added. Potassium iodate is the more stable form, and more commonly it is used for the salt fortification. And there are two techniques for the addition of iodine to the salt. So in the wet method, so where the potassium iodate is dripped or sprayed at the regular rate on a salt passing by the conveyor belt, or in the dried method, simply potassium iodate powder is sprinkled on the dry salt. And in India, the landmark.
Dr. Datta, sorry to interrupt. We are running over time. Can you just hurry up a bit?
I will conclude, sir. So in 1956, so the seminal study conducted by the Ramalinga Swami in the Kangra Valley of Himachal Pradesh, they noticed that iodine deficiency is a major cause of iodine goiter, and replacement of iodine reduces the risk of goiter. After that, in Government of India introduced National Goiter Control Program in 1962, and later it was changed. The name was changed to the National Iodine Deficiency Disorder Control Program. So the recommendation is at the manufacturer level, the iodine content should be at least more than 30 parts per million, and at the consumer level, it should be more than 15 parts per million. So to conclude, iodine is an essential micronutrient, and iodine deficiency has multiple adverse effects on growth and development. And iodine deficiency disorders are more important and common human disease, and which is the most important preventable cause of mental retardation. And it is easiest of the major nutritional deficiencies to correct, and still it is continues to be a public health problem. And the most effective way to control iodine deficiency is through the salt iodization. Thank you for patient evaluation.
Thank you, Dr. Datta Reddy, for that excellent summing up of exhaustive lecture on iodine deficiency, how we all started with the iodine fortification program and the disorders. Thanks for an excellent talk. There's one question from one of the person, Dr. Somasundaram. For which person you advise iodized salt?
Actually, every person should consume iodine salt, because the only source of iodine to human body is the iodine salt, because the plants which grown in our soil as well as water we consume has significantly less amount of iodine. That is the reason iodine salt should be consumed for every person. That is the reason most of the governments in the world recommends iodine salt is the mandatory. So they remove the general salt with the iodine salt. So that is reason everybody should consume iodine salt.
You can stop sharing. I will just modify the question slightly for the benefit of the audience. For which person you advise not to consume iodized salt?
Actually, we routinely advise non-iodized salt to the green disease hyperthyroidism initially, so that can reduce the production of thyroid hormones from the thyroid gland. So to prevent the severe thyrotoxicosis, we advise them to consume uniodized salt. But according to me, that is the only indication I know.
Yeah, absolutely. But how about salt prior to radioiodine therapy? Do you advise anybody routinely? Because most of the patients do ask, or somebody gives you that advice.
That is one of the important areas, sir. During what to say? So before the radioiodine therapy, we need to reduce the salt intake. So that increases the TSH value. So TSH is one of the stimulants for the sodium iodide importer. So that increases the entry of the radioiodine into the thyroid follicular cells, which increases the effectiveness of the radioiodine. So during that period, we need to we advise the patient to take uniodized salt during that period.
Thank you. There are no more questions. Thanks, Dr. Datta Reddy and Dr. Arun, for an excellent session. And we hope to have you in future Magna updates as well. Sure. I hand over back to Dr. Anand for further winding up session. Thank you.
So I asked Dr. Sudhakar Reddy to step in and sum up. I think, we've had very good deliberations. I'll ask Dr. Sudhakar Reddy to give us a vote of thanks.
Yes. So I hope all of you enjoyed this academic feast with excellent talks and perfect time management. And I would like to thank all the chairpersons for active participation and nice interaction. And I would like to thank all the speakers for their lucid talks. My special thanks to all delegates, organizers, and technical team. And last but not the least, sponsors of this wonderful academic event. Once again, thank you one and all. Take care, stay safe, and hope to see you all for next Magna Endo Annual Update 2022 in the same month, Feb. Thank you.
Thank you. Thanks, everyone. Thanks, everyone, for joining. Yeah.
Winding up note, happy Valentine's Day. At least rest of the day is there. You can celebrate.
Yes.
Bye. Take care.